مساء الخير. في الأول حيي السادة الحضور وبنحيي الأورجنايزنج كوميتي على هذا المؤتمر الرائع. ويعني أنا بحضر مؤتمرات بقالنا 30 سنة في المستشفى، ما شاء الله ده من أحسن المؤتمرات ومجهود مبذول واتندنس وانترناشونال سبيكرز. فبنشكر الأورجنايزنج كوميتي وعلى رأسهم الدكتور عمرو الحسيني والدكتور حاتم الجمل. هنتكلم النهارده في very hard and hot topics, advanced endometriosis, and we have the honor to invite Dr. Martin for impact of endometriosis and endometrioma in fertility and how to protect ovarian function. So it's okay, welcome.
Thank you so much, and thank you for the invitation. I'm the head of division of minimally invasive surgery, and it includes both robotic and laparoscopic surgery. I have a short agenda. It's a little bit about pathogenesis, anatomy, impact of endometriosis on fertility, especially ovarian endometriosis, but also a little bit about uterine endometriosis. Well, how interfere endometriosis with fertility? That's a huge question, and still we don't know that much. But we know it's about abnormal progesterone receptor function. We published a comprehensive review just recently discussing all the problems in this relationship. Well, what it's all about probably is that it happens in the fetal life, probably, or it starts in the fetal life. Inherent genetic modulations, environmental toxins will probably add to abnormal expressions of genes, and also retrograde shedding would also occur in fetal life, add to inflammation, and as a result, you have the progesterone resistance. And the end result is inflammation and growth, cellular growth, which is not inhibited by progesterone. That's a short presentation of the pathogenesis of infertility. In my mind, there's three types of endometriosis. There's the superficial, the ovarian, and the deep infiltrating endometriosis. Probably you all know that endometriosis invades both the uterus, it invades the bladder, the bowel, and the peritoneal cavity as well. Also the endometrioma we will talk about later. This is the typical lesions you see on the diagram. You see in the picture below the endometrioma adherent to the uterus, then the infiltration of endometriosis in the bowel, and last, the very complicated picture, invasion of endometriosis in the small intestine, the rectum, the ovaries, and the uterus. And this is a very complicated case to deal with. But go a little bit back and look upon the anatomy on the ovaries, because that's so important for our understanding on the protection of fertility in women with endometriosis. If you look upon the white surface on the ovary, you have a small, very thin layer, 0.3 millimeters. It's just covering the ovary. And just below that, you have the follicles. So if you harm the ovary, it's so easy to do, and then you will harm the function of the follicles. In the inner part, you have a hypocellular matrix, and it contains the blood supply to the follicles. If we look upon normal fertility, the monthly fecundity rate of normal couples, it's about 30% in average. But if you look upon couples with endometriosis, it's so much reduced, 2 to 10%. So due to the abnormal progesterone receptor activity and the inflammation and the restricted cellular growth. This is what happens in those couples. Can we measure then fertility? Is it possible to measure and to consult our patients in any way? Well, you probably know the revised American Society for Reproductive Medicine classification system. This has been known for many years, but it only describes the place and the extent of endometriosis. It does not relate to fertility. It does not relate to pain either. So you can use it for consulting your patient in description of the place of endometriosis lesions. Recently, we had the Indian classification system. It's very well organized, and it also describes in details the place and the in-depth of the invasion of endometriosis. Well, unfortunately, it does not relate to fertility at all. It relates to pain, but the relation coefficient is very low, 0.2, so it's very difficult to use as a form to inform your couples about fertility. And then you finally have the endometriosis fertility index, which is a mixture of different forms. It includes also historical data, and you end up with a score. And you can see from this slide that the score is actually related to the success rate in relation to baby take home. So if you have this form and you have a score beyond 6, you can tell the couples that they will have a 60% chance of having a child within 3 years. But honestly, it's complicated to use, and I don't use it. Well, what else can you do? Well, you can measure the anti-Mullerian hormone, the AMH. You probably all heard about it. And I think it's the best biochemical marker of the ovarian reserve and relates also to the number of anthract follicles. And then, of course, you can measure the number of anthract follicles. If you look upon the AMH in normal, healthy women, there's not that many studies including healthy women. You can see that the maximum is about the age of 15, and when you become 40 or more than that, the AMH is very low. If you look upon this picture in women submitted due to infertility, you have pretty much the same picture. What about patients with endometriosis? This study demonstrates the level of endometriosis in controls, which is healthy women. Those with superior endometriosis or superficial endometriosis, those with ovarian endometriosis, and those with deep infiltrating endometriosis. And what you can see after surgery, you can see that the level of AMH declined much more in cases with endometriosis than in those with cyst or dermoid cyst, which is the other two groups. At the start of this study, you could see that the level was equal in all three groups. So surgery whatsoever decreased the level of AMH. We know that a part of the AMH will reverse and come back not to normal level, but close to normal level in time. So my conclusion, and I think I agree with those conclusions, this conclusion is probably agreed upon by many surgeons, that AMH is an estimation of the ovarian reserve, but it does not reflect oocyte health, and it does not reflect the possibility to achieve pregnancy. And therefore, I think this should not be used to withhold IVF treatment. And I think still age is the best marker to achieve pregnancy. Let's look upon ovarian endometriosis a little bit. This is a review we did where we looked upon the fertility or baby take-home rate, which is the most important figure, I think, and we look upon patients undergoing surgery for endometrioma. And what you can see from this figure, that if you do surgery, you will not favor fertility. Probably you will decrease the fertility rate. It should be mentioned that this is done for cases, this is the case if the endometrioma is below 5 centimeter. It might be different in larger endometriomas. How to identify an endometrioma? Well, normally I use ultrasound scan in order to describe and detect the size, etc. But very frequently I use the MRI scan as well, because I think it's more effective in describing invasions and relation to other organs. But I think it depends what you're best to do. And if you're best to do ultrasound scans, well, just do that. But this is, in my opinion, the best way to identify the problems and counseling the patients. This is how an endometrioma may look like. You have the white, shiny surface. And what then to do? How can you empty or whatever with this case? This is how I do. I always control the puncturing of the cyst in order to avoid spreading of the content. After that, I dissect the endometrioma free from, in this case, the bowel. It's a little bit more complicated in this case. And the next step is to remove the capsula. I know that when I remove the capsula like this, I remove also oocytes and follicles, and it might be a problem, but this is probably, in my opinion, the best way to offer surgery and to preserve the fertility in women. If you don't control the incision of the ovary, you will have the content spread all over the abdominal cavity. So don't do that. Okay? So this is a short schematic presentation of what I think should be done. And whatever, the best way is to minimize the surgical trauma whatsoever. And you probably know there's a lot of different methods to treat endometrioma. You can do it like I just presented. You can do ablation using bipolar or laser technology, or you can inject alcohol for treatment. This is the laser, and this is the alcohol injection in the ovary. You just keep the alcohol in the ovary for 5 to 10 minutes, and then you use your suction and remove the alcohol. But whatever, compared to surgical treatment, you do not have better outcomes in relation to baby take-home rate, which is the point that matters to patients. The best way so far is surgical treatment and removal of the capsula. Well, adenomyosis is also a major issue in relation to fertility in many women with endometriosis, but it's also overlooked in many cases. And adenomyosis is something like endometriosis, and many things that it's a part of endometriosis, other things that it's different. What you see is invasion of endometrial glands in the myometrium, causing pain, etc. I will not go into that one. But if you have, or if the patient have adenomyosis, it has clearly a negative impact on the fertility, and the baby take-home rate is decreased compared to normal couples about 10%. But what also is a huge problem is the miscarriage rate, which is much higher than in normal couples. So what you have, you just have a very high miscarriage rate in case with adenomyosis, and you have to deal with that in consulting patients. I use mostly ultrasound to identify adenomyosis, and the first thing I look for is ectopic endometrial glands in the stroma. Secondly, I look for muscular hyperplasia or hypertrophy, and finally, increased vascularity. But there's no clear definition of adenomyosis. It can be seen on the ultrasound like this, like hypertrophy of the muscular layer, or it can be seen by the MRI scan like this. And what you have to look upon is either focal or diffuse endometriosis, and that's make surgery very complicated. So what else to do? You have different medical options, but you also have maybe in the future something called HIFU treatment. This is highly intensive focused ultrasound. It acts like you scan the patient using MRI scans. You can see the adenomyosis, you induce heat in the area, and you end up with necrosis. We do not know if it's superior to surgery, but currently there's no study demonstrating that. You have other options like cryopreservation, and we do that in some very few cases where you prepare the cortical tissue in small strips, you freeze it, and you reimplant it like this in the ovarian remnant or in a pouch where it acts and can be stimulated like normal ovarian tissue. So my take-home message is that women with endometrioma has same fertility rate as women without endometrioma, unless it's maybe more than 5 centimeters. Surgery due to endometriomas decrease fertility measured by the AMH. And surgery prior to IVF does not improve outcome. So far, no randomized trial has shown improved fertility. But in case of infiltrating endometriosis and pain, sometimes it might work to offer surgery. And finally, repeated surgery does not improve fertility outcome. So thank you for your attention.
Thank you, sir. In terms of endometrioma, you are in favor that surgery will not benefit the patient regarding her fertility, except when the endometrioma is large and it will hinder some kind of IVF or things like this.
Yeah, I think when we did this study or review on endometrioma and fertility, we could see that there is a limit. I mean, if you have an endometrioma beyond 5 centimeters, then you might improve fertility. And that's because you have difficulties getting access to the ovary. There might be another option too, and what we are considering currently, what we do is at the first time, we just do a simple laparoscopy, empty the cyst. Then we offer the lady fertility treatment and retrieve oocytes. Then she will go for further surgery, and finally she will go for a IVF treatment. Okay. So it's a complicated process, expensive, etc.
All right, this one thing. The other one, for deep infiltrating endometriosis, removal will not benefit the patient in terms of fertility also.
Could you please repeat it?
For deep infiltrating endometriosis.
Oh.
The DIE, the DIA.
I don't.
You categorize endometriosis into those with endometrioma, those with peritoneal or superficial endometriosis, and those with deep infiltrating endometriosis.
I'm sure that I understand the question.
Okay. All right. Thank you. the audience, any question? Thank you. What's her name? Now with the glance into the future of endometriotic surgery by Dr. Rennie Wenzel.
So, dear audience, dear chairpersons, thank you very much for inviting me from Austria here to talk about a glance into the future. I'll show you some specialists of endometriosis. The specialists of endometriosis, the Beatles, why the specialists, they wrote a song. It's called The Long and Winding Road. It's not only a long and winding road with the symptoms for the patients, but it's also a long and winding road for the people taking care of the symptoms. And if you want to do a glance into the future, I want to show one of the most excellent soccer players in the world, Mo Salah. And if he's preparing for if Mo is preparing for his near future or the far future, he's probably thinking about three things: of improving his already perfect technique, of his primary endpoint, gaining the match, and of his strategy, adapting to the different situations he has, if he's playing at home or abroad. And if we're talking about the technique, which is in every hospital and also with Mo Salah, a perfect technique, you probably have to adapt it a little bit. We are trying to adapt our technique. We are not actually using ICG in our patients, but we will induce it in endometriosis casing to see patency, who probably check the anastomosis of the bowel and probably see whether this bowel anastomosis has enough blood supply. And the other thing is we want to see whether our improved technique with using the robot in prospective randomized trials will have a better benefit on pain improvement or on less decrease of AMH, as my speaker before me told you already. But these are only small adaptations in the technique. More we are talking about the primary endpoint. Mo knows what his endpoint is. He wants to score more goal than the other team. But do we really, as a surgeon, know what our primary endpoint is? If you look at the publication Future Direction in Endometriosis Research, the authors are clearly stating that clinically relevant endpoint in future studies have to be found. Because at the moment, I think we don't have found the correct clinical endpoint in endometriosis studies. What are we using? This is a picture from Marcello Ceccaroni in Negra in Italy. And if you look at the picture, he's stating that it's dysmenorrhea of VAS10 and dysgeusia of VAS7. But this is really a good endpoint. Is a dysmenorrhea of 1 day of 7 more than a dysgeusia of 5 over the whole cycle? It's difficult to compare just the number. Probably have to count the area under the curve of problems of endometriosis during 1 month. So I think the VAS as a single point is not a good measurement for endometriosis and for the reduced quality of life patients are having. And the VAS is also not a real good endpoint for problems with the bladder. This is a study we performed together with Fabio Gezzi in Varese, which is near Milano in Italy, and where we tried to find out whether endometriosis is the cause of problems with having bladder dysfunction or the surgery is the cause when we are resecting deep infiltrating endometriosis. And we found out that endometriosis impairs the bladder function even if the patient doesn't recognize it. If you do urodynamic measurements, you see that you can improve bladder function in patients having the problems with urge incontinence symptoms. And so endometriosis is the cause because it has problems with the nerves, and if you relieve the nerves and if you relieve probably the infection, then the urge component of endometriosis patients measured by urodynamic function is much better. So endometriosis is not only a VAS score as an endpoint parameter. So what we use at the moment is a questionnaire. A questionnaire better resembles the problem over the cycle, better resembles all the symptoms patients have, all the symptoms of pain and all the dysfunction of bladder and rectum. So we use the endometriosis health profile 30, which consists of 30 questions which the patient evaluate for the last 4 weeks, and which better tells you about the function or the decrease of quality of life in endometriosis patients. And you can see that the black line is the one which resembles all the patients. Sorry, the black line, the dotted black line is all the subtypes of endometriosis, and you see over the long term the improvement during after surgery is even not only established but even much better than after 6 to 8 weeks. And the end point on the far right is more than 4 years after surgery. And this is not only with repeated surgeries, but we have a reoperation rate in our 100 patients of only 8. And only the major point of having a reoperation in endometriosis is that when patients have an endometrioma, because the recurrence rate of endometrioma is quite high. So what you see that especially deep endometriosis starts from a very, very decreased quality of life and gets better over the years, and after 48 months the effect of your surgery is quite good if you try to reach a complete resection of endometriosis, which is our protocol. So probably we should measure the quality of life decrease by EHB 30 in the future and not only by VS. And the major part is strategy. Mo Salah will adapt to where he plays, against whom he will play, with all his partners in his team. So every match has to be adapted. And in the near future and in the far future, we have to adapt with our strategy how we do the operation, how we do surgery in patients who come to us with problems caused by endometriosis. So I think this is written in all books that you have to perform diagnostic laparoscopy in patients with endometriosis. But is this really true at that point? To my opinion, no. Because diagnosis of endometrioma can be done, and we are doing a lot of vaginal ultrasound, can be done with high significance and high specificity with ultrasound. You find this endometrioma by ultrasound. So you don't need to diagnose an endometrioma by ultrasound. You have to do diagnosis with deep infiltrating endometriosis by an operation. You cannot do it because you don't see it, but you see it by ultrasound. Or probably if you are experienced with ultrasound that much, you can do it by MRI. But you don't need an operation to diagnose deep infiltrating endometriosis. And I think peritoneal endometriosis is not the case to diagnose it, because if you look at the red line is the one with our patients with peritoneal endometriosis. So they start from a very good point before surgery, and the amelioration, the improvement of quality of life is not that good. So probably you could operate peritoneal endometriosis, but definitely you don't need to diagnose it by laparoscopy. Laparoscopy is an operation. And this also questions Andrew Horn in Edinburgh in Scotland. He questions whether the resection, it's an ongoing trial, the ESPRIT trial, it's a question whether endometriosis has to be peritoneal endometriosis, superficial endometriosis has to be operated and has to be resected, but because probably you don't have a lot of benefit in resecting peritoneal endometriosis, and probably you stick with medical treatment. And so I'm completely the same opinion as Charles Chaperon. What we have to do is restrict operations, because operations are harm. And if you look at the first line, the highest up line, then patients 20 years, 15 years probably at the moment, underwent repeated operations when they had endometriosis. And I think this is out of time. You have to restrict the operation around the time of when they want to get pregnant and cannot get pregnant, or when they have problems with vital organs like the bowel or like the urinary system. Or probably in the bottom line, you don't need to operate the patient with endometriosis because she is fine with medical treatment. And with restricted resources of access to the OR, probably the last line is due to patients who do not suffer that much and they don't need a diagnosis of peritoneal endometriosis. And the other forms of endometriosis you can diagnose by ultrasound or MRI. Endometriosis is that complex that Jörg Keckstein will tell you tomorrow about the classification, and to my opinion is the only classification which comprises all forms of endometriosis. It comprises problems like diaphragmatic endometriosis, endometriosis of the pelvic organs, retroperitoneal endometriosis, and to my opinion, it's at the moment the best. And what we want to do, and this is a study of Germany, Austria, and Switzerland, what we try to do with finding 500 patients, we want not to classify endometriosis by this Enzian score, but we want the staging, like in oncology cases, want to stage the patient. If she has a compartment to the side wall, retroperitoneal, then she probably has more pain and the operation will give her more improvement. So with these 500 patients, hopefully we will find a classification which offers you also a staging like in oncology cases. Probably I can report it some years later. And what the problem is, deep infiltrating endometriosis causes so many problems also with vital organs, and you don't have to miss this problem before you do the operation. You have to look for the kidney probably if there is a dilatation of the urinary tract. Before you have to know it before, if you have to prepare to lyse the ureter, have to be aware to have the potency to lyse it or to reimplant it. So it's a difficult disease. And this difficult disease is defined by Marcello Ceccaroni in Negra in Italy. He says, and probably it's not right, but he says it's more difficult than oncology surgery. But if it's not more difficult, it's definitely very difficult. And you have to be aware that this technique has to be, you have to have a lot of operations, and you have to have colleagues covering the not gynecologic organs like bowel and urinary tract. And so you have to be prepared, and you only can be prepared by knowing before the operation what you are expecting. And this is just to tell you, this is abdominal wall endometriosis, and we see about 10 cases. This is not the case, but in this video you should see a patient. She had 45 kilograms and had a 14 centimeter endometrioma after cesarean in the abdominal wall. And she had so much pain that we had to resect half of the rectus muscle on the right side. And this went through to the peritoneum. It was a huge operation. And we had to implant a acellular matrix to stabilize the abdominal wall. You see the excision, this is quite big. But you will encounter these cases because endometriosis is going on and on. But you have to be aware that endometriosis and any surgery can cause harm. And so you have to restrict the operation probably to one per woman in her life. Harm, harm like side effects, like peri and postoperative complications. And if you have more challenging operation, more complex operation, definitely your rate of complications will go higher. So the more difficult the operation, the more you have to be prepared, the more cases you have to have. And it's also the impact on fertility. Paolo Vercellini told us that if you do more than one operation, the impact on fertility and getting pregnant is decreasing. So on the left side, it's just one operation. On the right side is the chances with secondary operations. You're decreasing the chance that the patient will get pregnant with multiple operations. So restrict the operation to one. And there are also very harmful problems like death. Death associated with anesthesia. And if you look at the upper value of the confidence interval and you do a multiplication with the laparoscopies done on easy laparoscopy cases in Austria, and you do this, then you have 100% chance that one patient will die according to an easy operation due to anesthesia problems. So be aware that operation has to be planned correctly and thoroughly. It should be no surprise that you find this deep infiltrating endometriosis during a diagnostic laparoscopy. This can be found preoperatively by ultrasound or MRI. Be prepared for this situation. So this is Hans-Georg Eichler. He was the chief of the European Medical Association in London. And he said, what is fact today has to be questioned tomorrow. So probably what we did the last year, we have to question in terms of strategy. We have to look at the problem before we do the operation, to restrict the operation to one operation and to do a correct operation at one time. That's what we try to do. I'm coming from Vienna. We have a certified endometriosis center which deals multidisciplinary with pain doctors, with anesthetists, with general surgeons, with plastic surgeons, and with urologists, and dealing the complex cases together. We only go into the operation if we know what we have to expect. And that's what we also having. It's a fellowship for endometriosis. We're trying to establish a route for these persons who want to deal with endometriosis in the near future, and they undergo a 2-year fellowship. So be aware, you have to have, before you do the operation, an informed consent. And it's not only the consent of the patients, also the surgeon has to be informed about the extent of the operation. It's not like that you go in and say, oh, I don't know, I didn't know that there is an iceberg in the rectum. You can know it before. And if you're not aware to do it yourself, just send it to MRI, or send it to anyone who does the ultrasound. The strategy is the thing which is important in endometriosis. The strategy and the preoperative finding. Then the operation, it's just handwork. But before, this is essential, and I want to stimulate you to look for deep infiltrating endometriosis before the operation and not be surprised. I think any diagnostic endometriosis, when you find the surgery, when you find deep infiltrating endometriosis, is harm for the patients. And this is read the signs, which is endometrioma always are associated with deep infiltrating endometriosis. They always have deep infiltrating endometriosis, especially when they have kissing ovaries on both sides. And if the patient has dyspareunia, then also it's very often associated with deep infiltrating endometriosis. You don't have to be a specialist of ultrasound. You have to read the signs, read the symptoms. And so I think this is the new future, the glance into the future in endometriosis. It's a little bit of technique. We have to define the primary endpoint. And it's a lot of strategy before the operation and also during the operation. And then I think we can restrict the operation to one time and do a residual-free operation. And this is just thanks to my team.
Thank you very much. This is very impressive. And you really got our attention with the Beatles and Muhammad Salah. I had the privilege to be working in Liverpool Women Hospital between 97 and 2000, and I fell in love with the city, and I'm a big fan as well of the Beatles. So you got me both ways, and the presentation is amazing. Thank you very much. Now we move to the next speaker, mine, Mr. Angus Thomas. Angus Thompson is the Secretary for the British Society for Gynecological Endoscopy. He's been with us for the past few days, helping us with the basic laparoscopy and advanced laparoscopy workshops. He was among the first surgeons to work in our new modular theaters. We really appreciate his efforts, and he's going to address us about the UK Endometriosis Centre, what comprises a good service. Please, Angus.
Thank you very much indeed. It's a great privilege to be invited to speak here with such eminent speakers, and thank you to the organising committee. And it's a wonderful congress, it really is. I'm going to speak to you about the UK Endometriosis Centres and what comprises a good service. And really, what are we aiming for? Well, we're aiming for a gold standard in endometriosis care, and what does that look like? In the UK, we currently have 75 accredited and 11 provisional endometriosis centres. I'm going to speak to you about how that's come about, but also what potentially is the future. I also want to point out that this is a concept that's only been around for 20 years, has only actually come to fruition in the last 15 years, and this is something that very much, if you've got the drive to do it, it can be achieved. And what we've seen here in the last couple of days with the modular theatres, etc., at the hospital, is there is really a drive to do this here in Egypt as well. I work in the Worcestershire BSG Endometriosis Centre, but I'm also going to make my claim to Mo Salah, because I was also in Liverpool 20 years ago, or 25 years ago. That's where I did most of my training. And that's why all my kids were born in Liverpool. They all support Liverpool, and go Mo Salah, fantastic. Anyway, where does the BSGE come from? The British Society of Gynae-Endoscopy was started by a group of like-minded gynecologists in 1989, realizing that laparoscopic surgery was the future. It covers all aspects of minimally invasive surgery, including hysteroscopy, laparoscopy, and increasingly robotic surgery. I think one of the key factors about the society is it not only has consultants and specialists, it also has nurses and trainees as part of that society as well. And we also have overseas members as well. And we concentrate, much like this conference does, on education, training, standardization, and development. In the BSGE, it was recognized that endometriosis and the management of chronic pelvic pain is complicated. Endometriosis can affect other parts of the body apart from just the uterus, tubes, and ovaries. It can cause symptoms and overlaps with symptoms in muscles and nerves, gynecology, psychology, gastroenterology, and urology. And so if we're going to address this, we need to try and have a plan, because at the moment, or rather 20 years ago in the UK, the provision of care to women with endometriosis and chronic pelvic pain was very, very different. You might go to one consultant and have one experience, other consultants, a completely different experience. So, a group of clever people, after the 2003 Endometriosis Congress in San Diego, decided that we in the UK needed to improve our care, get together and work out how we're going to provide endometriosis care and pelvic pain care for the future. They decided they were going to establish centres for the treatment of rectovaginal endometriosis, and they would do this by looking at outcome data, complications, symptom improvement, quality of life, and all of this would be used to improve care. So the proposed aims of the BSG endometriosis centres was that standardisation, to audit our complications and outcomes, to drive improvements and establish benefits. As an aside, it was also hoped that we could find out how much good care costs. Because as you know, we predominantly work in the NHS in the UK, and there's always a problem with funding. But if we could prove that good care costs more, hopefully we could use that to make sure it was adequately funded. Really important. This is about a multidisciplinary team. You'll see here that the gynecologist trying to do everything is a one-man band. And trying to do everything, you're probably never going to be quite as good as the multidisciplinary team. And so maybe we as the gynecologists need to become the conductors. We need to be able to look after our string section, who are the colorectal surgeon, our brass section, who are the urologists, our percussion, which is our endometriosis nurses. But we need to work as a multidisciplinary team and recognize the benefits that all bring to it. So when we set up the centres in 2008, after the initial inception in 2003, there were 4 accreditation criteria. The first was that we must work in a multidisciplinary team, having gynecologist, specialist nurse, colorectal, urology, radiology, and pain specialist all involved. I personally would also add physiotherapy, but that's another thing. We would have to audit our data, and it all has to go onto a national database looking at pre, peri, and post-operative data, up to 2 years after surgery. Surgeons would have to have an adequate throughput. Huge arguments about what adequate throughput means. The decision in the end was 12 cases per surgeon in each centre. That's 12 cases of deep rectovaginal endometriosis. And finally, as an attempt to try and quality control, every unit has to submit a 3-minute video of a full operation in 3 minutes every year to make sure that people are doing the right sort of surgery. As I say, at the moment we have 75 centres in the UK and 11 in provisional centres who are hoping to become accredited centres. I'm going to come back to that because there is a suggestion that maybe we've gone too far. I was speaking earlier, and in Denmark, a population of 6 million has 3 major endometriosis centres. We are at the stage where we're about 900,000 population per endometriosis centre. Our centre in Worcester, although Worcester's only a small city, covers a population of about 1.4 million. So we need to find the balance of what's about right. I'm not going to go through this in detail, but we collect an annual data set and every unit is told what they've done that year, and this is data which they can utilize to move themselves forward as a centre. I would say this is useful for benchmarking. And benchmarking is a big thing across the NHS in the UK, and this is where we compare ourselves, compare our organisations, its operations and processes against other organisations, so that we can see if we're doing a good job or a bad job, or whether we are middle of the pack. The advantage of the Endometriosis Centre is that we have been able to make some publications, and this is audit publications. This is not randomised prospective studies. I accept the problems with that. But this study in 2018 included cases from 51 hospitals, over 5,000 cases of rectovaginal endometriosis. And what it did show is decreased pain scores and bowel symptoms, which were sustained until 2 years at least, and also an improvement in global health score, up to 80 out of 100. It also demonstrated what the rates of complications were. And this is very useful because it has been mentioned already this afternoon that complications will occur. And getting an idea in this large series of what complication rates can be expected can be a very useful thing, because when the complications occur, we all hate it. But actually to realize that it's expected is important. But equally, if centers have a very high rate of complications, maybe we need some support, insight into that. Just to give you an idea of what the database tells us about bowel disease, well, it shows us that about a third of patients did not need any specific bowel disease. The vast majority had a bowel shave or a rectal shave, and then there were also a number of disc resections and probably more segmental resections. What we are seeing with time is that the disc resections and segmental resections, that they've stayed relatively the same in this, but actually the last couple of years we've seen increases, as I think people are becoming more aggressive and trying to use just one surgery and do it well. The number of cases that are being done each year has obviously been increasing as more centres come online, until it was 2020 when COVID hit. I'm pleased to say that we're back to pre-COVID levels and actually in excess of pre-COVID levels in the last year. The challenges that being an endometriosis centre or running these has developed is that some centres just can't achieve the numbers, and actually by rights they then lose their accreditation. Other centres have found it difficult with the submission of surgical videos, but it is an absolute requirement. We also have challenges getting colorectal and urology input into the centres, but this is a prerequisite for accreditation. And so if units or hospitals won't allow consultants, colorectal surgeons or urology to be involved and pay for their time, then they cannot be a centre. How to set up MDT meetings, I think, can be improved because there's huge variation in MDT meetings across the country. And I think the other thing to mention is that, as with all specialisms within our field of obs and gynae, it's about recruitment, retention and succession planning to make sure that when people are retiring, there are people who are moving in and the quality of care doesn't change or decrease. A brief word about the future. And I'm actually speaking a little bit less than my allocated 20 minutes because I know that my two colleagues from the UK have got some lovely surgical videos to show you. So I'm speaking for a little bit less so they can speak for a couple of minutes more. But what's the future in the UK? Because as I've said, we've got probably too many centres. But with the information that the endometriosis centres have given us, we are now going through our NHS commissioners, which covers the whole of England, but this will roll out hopefully to Scotland and Northern Ireland and Wales as well. And we are in NHS England going to commission centres for the future, which means they will be paid appropriately for the level of complexity of work that they undertake. We know that not all gynecologists can treat endometriosis, but probably every hospital needs to have somebody who has an interest in endometriosis so that they're adequately assessed, adequately worked up, and they don't end up with unnecessary laparoscopies with inadequate treatments, as has been mentioned already. So there will be, hopefully, an endometriosis angle to every hospital in the UK. But then there will be fewer, more specialist endometriosis centres. And the aim is for all women with endometriosis to have treatment with a specialist that has suitable expertise. A bit like the maternal medicine networks that were mentioned in the earlier talks this morning, we're looking at a hub and spoke. So that means that all hospitals will probably be spokes for endometriosis care, with the more specialist centres, maybe 1 per 2 million population, we'll see, but they will be the units or the hubs. There will be a much smaller number, possibly 3, of thoracic or neural endometriosis centres, and that's because it's a much more specialist thing. There's a whole load of work going on around specialised commissioning, and this slide's got too much in it, but I'm sure it's accessible to you. But this is how specialist commissioning and accreditation of centres in the UK will hopefully look once this has been agreed over the next 24 months. I'm going to say thank you very much and ask for any questions, and also say We've got a meeting in Northern Ireland next year. If there are no other questions, then I'll just allow the videos to come on.
Thank you very much, Professor Angus. I want to say, as a laparoscopist, endometriosis sometimes deserves surgery and deserves urgent surgery when it causes pain, and we find some endometriotic lesions in the uterosacral ligaments and the tubes. I know that endometriosis is a subperitoneal lesion, and we have to open the peritoneum in this area, the visceral peritoneum, to reach the endometriotic lesion. But you and the previous professors said that there is no role or little role in treating endometriosis by laparoscopy. But I find that even wash, the saline wash or ringer solution wash, makes it better in endometriotic patients as regards pain and infertility. You agree with me?
I'll certainly try and respond to that. I'm not saying that endometriosis is not the right, surgery is not the right thing to do for endometriosis. I'm saying it's part of it, and let's use our surgery to its maximum effect. And that's why I think that I know in my unit, over the last 20 years, all gynecologists have treated endometriosis to a certain degree. We've managed to improve our outcomes by not doing emergency surgery as much as possible, and by making sure that we transfer their care to an endometriosis specialist as much as is possible. But yeah, I still think, and I'm a massive operator, that's what I do, I'm an operator. I love the operation side of things. What I'm asking myself all the time is, am I doing the best thing in this patient scenario? And you're right, there are always going to be cases where operation is what they need.
Thank you, Dr. Angus Thompson. Gives me the great pleasure to introduce Dr. Vasilios Minas. He's an endometriosis expert from Greece practicing in the UK. He's the lead surgeon at the Endometriosis Center at St. Peter Hospital, and he runs many courses in complex laparoscopic surgery and endometriosis. And by the way, he is one of the few surgeons who have received training in neuropelviology at Professor Passover in Zurich. Dr. Vasilios, the floor is yours.
Hello, thank you, and thank you for the honor of inviting us to your historic country and to this beautiful congress. So I'm Vasilios Minas, and I will talk to you about the structured approach to excision of deep endometriosis and how this applies to different clinical surgical scenarios. And I will try to do that mostly through surgical videos of deeply infiltrating endometriosis. But if you take one message from this presentation, may that be the fact that the first surgery, I believe, is the best surgery for endometriosis, and this should be performed by appropriately trained surgical teams, not only an appropriately trained surgeon, but a surgical team that surrounds the surgeon. So we have come up with an acronym which we call SOSURE, which we have published at the Obstetrician and Gynecologist, the official journal of the Royal College of Obs and Gynae in the UK. And this summarizes essentially the fundamental steps that pretty much most proficient endometriosis surgeons will take to excise deep infiltrating endometriosis. Let's see what its letter stands for. S stands for survey and sigmoid mobilization. Usually this will be the first step in most cases of deeply infiltrating endometriosis. These are physiological adhesions of the sigmoid. They don't necessarily need divided as part of disease treatment, but they are but it's very useful to divide them to gain access to the pelvic sidewall, and also on the left side, and to gain access to the retroperitoneum and the left ureter. The ovaries will usually be stuck in these kind of cases, and usually we can detach them, perform an adhesiolysis bluntly and with a bit of sharp or energy adhesiolysis, but with caution to the ureter.
S stands for suspension of uterus and ovaries. This is an important step that we have found, at least in our practice, helps us a lot in performing surgery for deeply infiltrating endometriosis. We take a figure of 8 stitch from the posterior lower uterine wall, usually with a Vicryl 1 needle, and we bring this stitch in and we take it out from the abdominal wall with an endoclosure needle. U stands for ureterolysis. This is almost a mandatory step in most cases of endometriosis. Even if you don't have disease on the ureter, you want to see what the ureter is, particularly when you're working close to the uterosacral ligaments. R stands for dissection of the rectovaginal and pararectal spaces. And finally, once all anatomy is normalized, then comes the final step of the procedure, which is E for excision of endometriosis. So let's see how we apply this technique, these steps, in a standard case of shave of rectovaginal endometriosis. You can see that the rectum is stuck to the posterior uterus. The ovaries are drawn towards the nodule as well. So we start with S, our sigmoid mobilization and the survey of the pelvis to obtain an accurate diagnosis of the extent of our disease. As we said, these are physiological adhesions, but dividing them helps us gain access to the left pelvic sidewall and see the ureter. We then move on with uterine suspension, which is usually the second step in our practice, at least, for this kind of cases. You see that we're trying to take the stitch as low as we can to the lower uterine body on healthy uterine tissue. Obviously, we don't want to go through the rectum. And this helps us bring the nodule and the area of adhesions out of the pelvis, forward and upwards, and gives us access to that area. We use an endoclosure to pick up the needle, but also to insert it in the abdomen and the pelvis, and we lift the uterus with as much tension as possible without tearing it. O stands for ovarian mobilization, as we said. So this is the time to mobilize the ovaries, and also this is a good time to perform any cystectomies if required. If there are ovarian endometrioma and you perform the cystectomy at the beginning of the operation, then by the end of the operation, you'll be able to be happy with your hemostasis and satisfied that you will not have a bleeding ovary after you close. We suspend the ovaries again. Some people do this with specialized devices like the T-lift. We do it with a PDS 2.0 suture, and we put enough tension to give tension to our pelvic side wall tissues as well. The mandatory step of ureterolysis. In all our steps, if you notice, we start from healthy tissue and we move towards abnormal tissue. So we don't want to start the ureterolysis or dissection of the pararectals, for example, at the area of the nodule where it is abnormal. So we may start from further up where the tissue is normal. Here we're dissecting the left pararectal space. And again, we're starting from normal tissue, coming towards the middle where we have our nodule. In this case, you'll notice that we're using energy to dissect the rectum to drop the rectum down from the posterior cervix and posterior torus uterinus. And the reason for that is that there is a nice layer of fat between the rectal serosa and the uterine serosa. So that's protecting us. So we're moving with the ureterolysis, and sometimes it may be useful to do the ureterolysis first before you mobilize the ovaries, because when you mobilize the ovaries, you can have some bleeding from the pelvic side wall. It may be difficult to stop that bleeding with diathermy if you don't know exactly where your ureter is. So the approach is not a strict, rigid approach that you have to perform each step in a specific sequence. We can come back we can proceed, you can bypass a step and then come back to a previous step later on according to the surgical scenario that you're dealing. We are suspending the right ovary, again with the same technique with a 2.0 PDS suture. We're continuing our dissection of our pararectal and right pararectal and rectovaginal space. And only in the very end, once we have normalized our anatomy, once we know where each organ is, and we have viewed the rectal serosa as well, then we can excise endometriosis. And actually, this is the easiest of the steps from the procedure, and it's the very last step, once the anatomy is normal. In the end of the procedure, we perform a leak test for our bowel to ensure we haven't made a hole to it, and we release our suspension of the uterus, but may maintain, in some cases, the suspension of the ovaries to prevent adhesions, because it is thought that they may prevent adhesions for the ovaries. So this was a standard video of a usual rectovaginal shave of endometriosis. Let's move on to see how the same approach applies in a different scenario. This is a case with a large rectovaginal nodule fully infiltrating the rectal wall, but also the posterior vaginal wall of this lady. As you can see, she has little else endometriosis. She has almost no endometriosis on the pelvic side walls, no endo on her ovaries. The ovaries are completely free, and most of the endometriosis is located in the rectovaginal area. She has a lot of adhesions, and we're doing a hysterectomy. These were from a previous cesarean sections. And I want to show you a pitfall of entering the pararectal plane. So here we see this white structure while we're dissecting the left pararectal area. This is the inferior hypogastric nerve. Here we're trying to stay at the mesorectal plane because we want to mobilize the rectosigmoid because we're planning to do a segmental resection. And once we recognize the hypogastric nerve, which is important autonomic innervation to the bladder, we realize that we have to dissect it laterally because we don't want this to be transected while we are working on the rectum and performing a segmental resection. We're coming from right to left, from normal to abnormal tissue to dissect our rectovaginal space. And sometimes inserting a finger in the vagina helps with these cases because you can delineate the tissues. You can see what is vagina, what is rectum. And once we have dissected all our normal tissue in the pararectal and rectovaginal space, we're now coming to attack the nodule. There is some lateral infiltration in this nodule. It extends laterally, mostly with fibrosis, beyond the mesorectal plane. So that's okay. We can come back to that later. Because we have recognized the rectovaginal and pararectal planes, we can follow that line and go through our nodule. We're performing a partial vaginectomy, removing the part of the vagina, small part of the vagina, which has a full infiltration by the rectovaginal nodule. And this is a nice picture which shows you the course of the inferior hypogastric nerves, starting from the plexus coming down towards the uterosacral ligaments. These must be preserved, and there is a risk of injuring them in deep pelvic side wall endometriosis surgery and segmental resections. We're coming back to excise the remaining endometriosis, which has a bit more lateral extension beyond the mesorectal plane. We have moved the rectum out. We have transected the rectum, moved it out of the pelvis. And we're finalizing the excision of our endometriosis, in this case, before we perform a primary anastomosis for the rectosigmoid. We do this, we have performed the hysterectomy, as you can see, and suture the vagina, and we leave this step at the very end, the anastomosis, so that we do not disrupt the anastomosis and we don't do a lot of handling or operating close to it at the end of the procedure. So let's look at a different surgical scenario where, again, we based our surgery on the same fundamental steps. This is a case where we have suspended already the uterus and the ovaries. And you can see that she has pretty much a normal pelvis. And in fact, she had a diagnostic laparoscopy 2 years before this surgery, and she was told that she had only mild endometriosis. 2 years later, she came to our practice with left hydronephrosis. And you will see when you look a bit closer that she has a large left uterosacral ligament nodule, which encompasses the left ureter as well. There's a significant nodule on the right side, which luckily does not restrict the right ureter. But we are treating that first so that we can ensure that we have at least a healthy ureter at the end of this operation. So here is the step of the ureterolysis, once we have suspended all our organs and treating the nodule from the right ureter. Going to the difficult part, the left ureterolysis. We start from a normal area, moving towards an abnormal area. So we start almost at the pelvic brim. And we're now moving to the abnormal area. You can see that the ureter to my left Sorry, I'll try to play that again. He was working well in the morning. Next one, please. Yeah, that's the one, the previous. Yeah, can you move it about to the middle? Is that possible? Or you can play the video separately, it's number 3. That's it? Yeah, that's great. Can you move it to the middle, please? Roughly, or 2 minutes. Go back a bit. So in this case, we have endometriosis between the ureter and the uterine artery, and we decided to sacrifice this left uterine artery. which is what you've just seen was diathermizing, was the uterine artery lateral to the ureter before it crosses the ureter. So we have transected our left uterine artery because we had some bleeding at the ureteric tunnel. And I'm holding the uterine artery with my Maryland forceps at the top of the screen up, the transected distal uterine artery, and I'm separating the nodule between the ureter, the restricted ureter, and the uterine artery, trying to enter the ureteric tunnel. You can see we have a little bit of bleeding, but this is mostly from the venous plexus of the uterine veins. And we're now entering the ureteric tunnel, because in a lot of cases of hydronephrosis due to endometriosis, unfortunately, the disease is exactly at this point, at the ureteric tunnel, deep in the pelvic, low in the pelvic side wall. So in this case, we had to remove some of this parametrial endometriosis together with a small part of the distal uterine artery on this side. And we're now going to come back to the main bulk of the nodule, which is the uterosacral nodule, which has constricted our ureter. Fortunately, this lady did not have any loss of kidney function yet. So we're protecting the ureter with the suction irrigation. So the ureter is just lateral to my suction irrigation. And you can see the stricture point right at the point where it enters the ureteric tunnel. And we're now trying to resect the nodule from the uterosacral ligament. But the nodule is thick, and the uterosacral ligament, and it goes deep into the uterosacral ligament. So we want to see where the rectum is. We don't have any rectal disease, as you can see, but we're going to go back to our fundamental steps. And in a minute, we're going to dissect the left pararectal area, just enough, just a limited dissection of the pararectal area to recognize where the wall of the rectum is, so that we ensure that while we're transecting the uterosacral ligament, we don't cause any thermal damage or any sharp damage to the rectum. At the same time, we have a rectal probe inside the rectum, which is pushing it away from us. And now, with all the anatomy recognized, again, based on the same fundamental steps that I described you in the first, less complicated case, we can resect the remaining of the endometriosis from this complicated, from this case, complicated by hydronephrosis. So this is the end of this procedure. Video number 4, please. Now, the last case that I will show you today will prove the first point that I made, which is, I believe, the main message of this presentation. That the first surgery should be done, is the best surgery and should be done by properly trained teams. This is a lady with almost unrecognizable anatomy. She had an open and incomplete operation for her deeply infiltrating endometriosis. Some were outside England, some were in her home country, and a few years later she moved to England and came to our practice. The anatomy was almost unrecognizable. These are not endometriosis adhesions. These are caused by her previous surgery, an attempt to incompletely excise endometriosis by open surgery. She had a transverse laparotomy for it, so for which we didn't have much information other than the fact that she had a partial cystectomy on the right ovary. But we're moving again with our fundamental steps. We are suspended the uterus. We've taken a stitch higher up, close to the fundus, as you can see, because there are adhesions of the rectosigmoid high up. We're moving to the left ureterolysis, and blunt dissection in these very sticky cases can help sometimes because it reveals the embryological planes. We're now moving to right ureterolysis and dissection of the right pararectal space, always according to our fundamental steps. A bit of blunt, a bit of sharp dissection helps us recognize a little bit of anatomy step by step. And we're now starting to separate the rectosigmoid from the posterior uterus. This lady, these are not endometriosis adhesions. There is no nodule at this level to the rectosigmoid. I believe that this case, these adhesions so far, all that you have seen, was caused mostly by her previous surgery, which was most likely, and obviously it's difficult to talk about other colleagues, but most likely was performed by a non-specialist team. We're trying to reconstruct her remnant of her right ovary. You can see some permanent stitches there. So these probably have contributed to these adhesions. We know that based on the MRI, there is a bit of remaining ovarian tissue there on the right side following her previous incomplete ovarian treatment for an endometriotic cyst. We are moving back to our dissection of the rectum from the posterior uterus, and we have still not seen convincing endometriosis. According to our MRI, there's a nodule deeper down. We're taking a second stitch from the uterus, from the posterior lower uterus, now closer to the area, to our adhesions which are deeper in the pelvis. And therefore, a second lift can help sometimes reach the deeper adhesions. You may have to do the suspension in stages. And finally, it looks like we're reaching the actual rectovaginal nodule at the area where her uterosacral ligaments that would be. And there is, again, I don't know if you can see, there is again evidence of a permanent stitch. There's a little bit of a blue thread, as you can see there, from her previous surgery close to the uterosacral ligament. So it's plausible that she could have had a bowel injury as well during the previous open surgery. Finally, we're moving on to the rectovaginal nodule, and beyond it, beyond the actual rectovaginal nodule, we're finding healthy tissue within the rectovaginal septum. This is part of the nodule. You can see the brown stain that we've reached, and here we're moving finally to healthy tissue beyond the actual rectovaginal nodule. And you can see the fibers of the rectum, the pink at the bottom of the screen, which are healthy beyond the nodule. So back to our fundamental steps. We have normalized as much as we can the anatomy in this challenging case, and we're finally moving to excise as much endometriotic tissue as we can and as much fibrotic tissue as we can, trying to leave behind us and a pelvis as normal as possible as it can be, following, given the amount of adhesion pathology that this woman had in her pelvis. And again, we have followed the same fundamental steps that I described in the beginning. And I think that working in a structured approach for deeply infiltrating endometriosis, and having seen after a few years that you see a variety of cases, you reach to a few conclusions. And we think, as I said in the beginning, the first surgery for complicated, deeply infiltrating endometriosis is the birth surgery. And this, in our opinion, should be, in most cases, complete. There will be a few cases where the limitations will apply, or the discussion with the patient will be about non-complete treatment of endometriosis. We believe it should be done by excision and not by ablation, particularly for deep endometriosis. It should be done by minimally invasive techniques, whether that be robotic or laparoscopic surgery, but not by open surgery. And it should follow a structured approach, and that should be performed by a team experienced in the management of complex deep endometriosis. Thank you.
Thanks a lot for Dr. Vasilios for this scientific and hard presentation, and very exciting presentation and amazing videos. I know all the attendants and the audience have a lot of questions, but we prefer to postpone all questions in the last 15 minutes of the session. And now we'll go ahead for next speaker, Dr. Michael. His topics: optimizing surgical management for endometriosis from simple to complex surgery. The floor for you.
Okay, sure. Good afternoon, everyone. First of all, I would like to thank the organizing committee for having us. We've been here for a couple of days and it's been a lovely experience. So thank you, and thank you for inviting me to speak today. And thank you for inviting our BSG team. It's been lovely. So my name is Michael Adamczyk. I'm a consultant endometriosis surgeon, and I work in the southern part of England. I work together with Mr. Minos, who just spoke, and he had a lovely presentation. I work with the CMEC team in St. Peter's Hospital in Chertsey, as well as in London, and I'm part of the BSG team. I'm a BSG council member, and as of last month, I'm also a council member for the ISON Society. Okay, so moving forward, I'm going to be speaking really about optimizing surgical view, and this is going to be a tips and trips video. We will go into 3 different compartments with a couple of short videos, starting from superficial endometriosis to more deeper endometriosis. We will speak about the left pelvic side wall, which would be the lateral compartment. We will then move to the posterior compartment. We'll speak about rectal shaves, discoid excisions, and hopefully, if we have enough time, I'll show you a couple of videos with rectal segmental resections, and then we're going to move to the anterior compartment dealing with the bladder endometriosis. So, a little bit about SOCIA. Mr. Minas, my colleague Mr. Minas, spoke to you about it. This is something that we practice routinely. It's a structured approach to complex surgery, dividing the surgery into smaller steps, making it accessible. It's good for training. It's good for training the future generation of surgeons. But I would say that we're always evolving. And I would say that right now we're practicing SOCIA Plus. And this is really the nerve-sparing surgery, sparing the autonomic nervous neuroanatomy, sparing the hypogastric nerves. A little bit about suspensions. We use a variety of suspensions to access the pelvis. We use different types of uterine suspensions. We use different types of ovarian suspensions. At times, we can also suspend the vault in order to get into the posterior department. In order to perform a segmental resection, that gives us much more space. We can also suspend the bladder for ureteric implantation. We can also suspend the bowel itself to gain us access into the pelvis. Starting with videos, I think that's what everyone really wants to see. This is fairly simple excision of endometriosis from a pelvic sidewall. We've got superficial endo on the left. This is done with 2 instruments. My left hand is operating in thunder beat, which is advanced energy. My right hand is retracting the peritoneum immediately. I'm doing this sort of sweeping motion on the ureter, and that for me works really well. So the goal of this step is really to stay on top of the ureter, divide the peritoneum into 2 parts. We're talking about the left, which is the lateral part, the right, which is the medial part, and staying on top of the ureter. The video on the left shows how I deal with pelvic sidewall on the bottom half, which is the medial side. I stay on the peritoneum. I hug the peritoneum really closely. When I'm dissecting it down past the uterosacral ligament, I'm fairly sure that the hypogastric nerve is out of the way, and therefore at the end, all we have to do is just continue an excision of peritoneal disease, making sure that we're going slowly, retracting the disease laterally, and working our way around it, excising all the abnormal tissue. This is an interesting case. I would class it as a sort of medium to high level of difficulty. This lady had a full thickness bowel nodule. It was quite high. The bowel was particularly adherent to the ovary. We were hoping to shave it off quickly and perform the segmental resection. We attacked it straight with the thunder beat, but we realized that the ureter was being pulled into the nodule. So we went to the basics. We started with our uterolysis. We're going on top of the ureter again, and we're working slowly, visualizing the ureter at all times. It's important for those type of operations that we have a trainee with us, a colleague that knows how to operate, that's seen those surgeries a lot, because look what's happening over here. The amount of traction that we're pulling, medializing the abnormal tissue away from the ureter, it's actually quite a lot. It's okay to change the instruments. It's okay to move from Maryland's to Johans to suction irrigation. At this stage, I'm trying to get past that ureter, to get past that abnormality, but I'm swapping it with suction, okay? I'm trying to see now if we can mobilize it with blunt dissection, if that nodule is giving or not. It's playing with tissues. It's seeing how much you can get away with in a safe way. I couldn't, so therefore we went back with suction with Maryland's. We're trying to get past that disease again. And what's happening at the moment that once we pass the ureter, now I can safely block it with my suction irrigation and cut into the nodule. This was a nice view right now. There was this herniation of pararectal fat. That means to me that we're winning, that we're shaving the disease off. And at the end, all we have to do is divide the bowel, divide the nodule away from the pelvic sidewall, excise the rest of the endometriosis. We did a hysterectomy over here, and you can see there's end-to-end anastomosis and complete reuterolysis and excision of the pelvic sidewall. This is a really interesting case. So I would really class this as a difficult pelvic sidewall. At first instance, it looks fairly normal. It looked normal to me. This lady never had any previous surgery. Once we started doing uterolysis, I've noticed that the ureter is going very laterally, and I knew that something wasn't quite right. We were performing a hysterectomy, so the goal was really to remove the uterus at the end, so we've opened the broad ligament. Look what's happening over here. She had a complete peritoneal retraction. So her peritoneum on the side, on the pelvic sidewall, folded on each other with a rather large nodule that was extending almost to the sacral nerve. Certainly, it was on her hypogastric vessels. So slow molecular movements. Again, my assistant is blocking the ureter with his suction irrigation. He's cooling it off with a bit of suction, and we're working slowly in order to perform uterolysis. And the same principle applies. Stay on top of the ureter, go as high as you can. This peritoneum didn't behave like a normal peritoneum. It looked like sort of this very leathery peritoneal texture. It looked like previous excision surgery to me, or it looked like a previous infection, but she had none of those. Nevertheless, we're moving slowly, we're protecting the ureter at all times, we're delineating the nodule, and at the end, we're going to be excising that little nodule. This patient had actually had some sciatic symptoms. We didn't go as low as the sacral nerve roots, but releasing the pressure from that area and completely dissolves her sciatic pain. Okay. Now moving to the posterior compartment. I've got two videos of shaves. The video on the left is really not a shave of rectovaginal disease. It's really a pararectal sort of disease. We're starting with the same. We're going into the pararectal spaces. I like to use in my left hand, on the right hand side, a non-traumatic grasper, a small Johans. This is a bipolar Johan, works really, really well for me. And we're slowly medializing the bowel. We're slowly moving forward. The thing about the bowel is that we have to remember that the bowel is like a shark. It goes from left to right. Be careful when you're cutting it, because you will see in this point right now how easy it is to actually nick the bowel with your advanced energy without realizing it. Once the bowel is delineated, once the bowel is moved to the left, we can then slowly excise the remaining of the disease. And it's always surprising how deep the disease actually is. This is not a particularly challenging case, but from the first look, one could argue that this is quite a superficial disease. At the end, we've got a small nodule that is about 1 centimeter in size, so with a nice hypogastric plexus left behind. Another rectal shave. This is slightly perhaps more difficult one, purely due to the nature of the disease. It's a little bit more vascular, there was a little bit more bleeding, but again, the same principle applies. We're going with the pararectal spaces, we're medializing the bowel, we're going past the disease, and once we move from the left to the right, we leave the abnormality in the middle, and there was a little bit of rectal tethering in the front, as you can see over here. We're going past it on both sides, and the safest way, in my opinion, to do it at this stage would be to swap from my advanced energy into scissors and shave the disease off. Scissors have an advantage that we're not going to have an thermal spread, okay? Even if we cut into the rectal muscle, we can always reinforce it with a little bit of sutures. And once the bowel here is dropped completely, we then move to excising the uterosacral endometriosis. And again, we're just playing with tissues. We're trying to see how much we can get away with without actually damaging any of the structures. Traction, contratraction is very important. We're pulling the abnormality away from us, trying to excise only what we need to. And this was just the end of the operation, really trying to clean as much of the bowel as we can. Over here, we're going to see quite a nice, clean plane of fat between the rectal wall and the rest, I would say, of the abnormality. Of course, we need to be realistic. We're not going to be able to 100% excise everything without actually going deeper. But whenever there's a laceration at the end, it's just important to put out a single stitch, perhaps maybe 2 sutures to reinforce the bowel wall. Vicryl tool works really well for me for this. It takes literally maybe 20 seconds to do, but it really reinforces the bowel wall. Right, moving to discoid resection. So I'm giving you a little sort of showdown of the things that we do in our unit. Discs are, I would say that we do more and more discs nowadays than we used to. Our cutoff for discs are nodules that are smaller than 3 centimeters in size. Single nodules for nodules that are bigger than 3 centimeters, 2.5 really upwards, or multiple nodules, we would be doing a segmental resection. We go again into the pararectals. I'm using a rectal probe over here, which is the rectal manipulator. And again, it's a similar surgery to what you've seen already in the last two presentations. The steps of it are the same. That's why most of our trainees that come to our unit end up working in endometriosis centers, and they feel comfortable doing the surgery because you can divide various steps of this operation into smaller tasks in order to achieve a bigger goal. At the end, we need to drop the bowel down, make sure that it's completely free. My tip for this part, sometimes the rectal manipulator can be a little bit on a way. So if you're struggling, take the rectal manipulator out at this stage, and then you can easily get into the rectovaginal space. This was a case actually done later on at night. Well, it was one of our last cases. That's why we've dealt with the bowel first, so our colorectal surgeon could go home while we're excising the rest. This nodule was small, okay? So I was happy just to put a single stitch directly into the nodule with a Vicryl, put the circular stapler in. That would be done by colorectal surgeons, and then we can close it off and excise the rest of the disease. You can see a lovely hypogastric nerve on the right over here, and we're excising all the abnormalities. This would be the butterfly, so-called butterfly area of excision, and we're working slowly in order to get all the disease out. This is the torus, and we try to do it as much as we can on block. And this is a final picture. Okay, now this is another disc, but this is a completely different type of disease to me. You can see that the endometriosis is much more inflamed, it's much more vascular, it bleeds much more. This patient wasn't downregulated, she wasn't on hormonal treatment, but neither was the last patient. They were both in a similar age, but this is just much more of an inflamed disease. This patient also had a much higher BMI than the first person. But we're sticking to the same principles. We're doing our uterolysis. In this case, I'm using my suction quite a lot with advanced energy. Once I get past the ureter, I can go centrally and tackle the rectovaginal disease. Now, although this patient had a high BMI and everything else was quite much more challenging than for patients with lower BMI, the one thing that is positive on this is that I know that there would be a safe plane between the rectum and vagina. There would be some adipose tissue that will protect the rectal wall from the hot Thunderbeat instrument. And that's what we're seeing here. We already passed it. All we have to do now is to completely drop the bowel down from the rectovaginal space, create those planes, and then do a disc excision. For discs, it's important to clear the bowel wall off, especially when we're going to be applying the circular stapler. This is exactly what we're trying to do over here. What I'm doing is that we're trying to get all the pararectal fat away from the rectal wall, okay? And this is done really for two reasons. Number one is that we want to debulk the nodule as much as we can. We want to be able to fit it into the circular stapler. Number two is that we want to get rid of all the small vessels that run in the pararectal fat. And that's really to avoid any embarrassing complications directly postoperatively, such as bleeding per rectum straight from the surgery. With the larger nodules, we take two stitches. We take one proximally and one distally. Once the circular stapler is placed in, we then close it. We tie the knot in, feed it to the stapler, and perform a discoid excision, of course, with a Michelin's test at the end. I think I will have time only for one video of the segmental resections. You've seen the previous presentation that showed another video, but this is a nice video that will show you how to identify a hypogastric nerve. It wasn't particularly challenging. We're starting with uterolysis. We're lateralizing the ureter as much as we can. We're working slowly on the ureter, playing with the tissues. Our assistant is retracting the peritoneum on the side. We're doing a hysterectomy for this patient at the same time. So you can be opportunistic. You don't have to do everything in the same order. The tube is on the way, remove it. If this patient is having a hysterectomy, it takes 10 seconds to remove the tube so we can get a better vision. Now the ovary was slightly adherent to the bowel. Yes, there's a plane of fat, but if you worry, use scissors, go with cold scissors, okay? You will feel better once you see that the bowel is completely away, like over here. You can then move forward, okay? Change back to your advanced energy and deal with the remaining of the disease. mobilize the ovary, suspend the ovary, going into your panorectals. Now, I'm going backwards on myself over here in this video. Instead of opening the panorectal spaces forward, on the right-hand side, I went backwards. It's the same operation, it's the same technique, but you can be flexible when it comes to it. Over here, we're going to the left panorectal space. Again, cleaning the bowel. You can see I've opened the rectal serosa a little bit, but we dropping the bowel. This patient was having a segmental resection for a full thickness nodule. We're cleaning off the bowel where the stapler, a linear stapler is going to go, and this is the full thickness nodule. Now, the only thing that we have to do before we hand over to our colorectal surgeons is to actually excise all the endometriosis from a pelvic sidewall. We do that, but in this case, I wasn't sure if the hypogastric nerve was actually going into the little nodule or not. We stick to our basics, okay? We go back, we try to find the hypogastric nerve, dissect it. It's right over here. You can see it coming down right there, and try to lateralize it as much as we can before we start the excision. Right, I'm aware of the time, so I'm gonna skip this video, but we're gonna go to the anterior compartment. The video on the top left is a really sort of superficial endometriosis of the peritoneum. This was actually done by one of my trainees. It's straightforward. You don't need to apply, you don't need to fill the bladder at all. You can just excise it. The interesting video is the one on the top left corner, and I would really call this pretty much a bladder shave, really. That's what it is. Because you can see the bladder muscles being completely tethered into the nodule. The trick really here is to go extremely slowly, gently push away those tissues. Fill the bladder with 250 ml of saline. You can add some blue dye into it. If you have ICG, you can add that into your saline. The benefit of ICG is really that if you do open the bladder, you won't have any blue spillage in. You will still have your clear view. And we go just going gently, moving the bladder away from the abnormal peritoneum. The video on the right is a full thickness bladder nodule. This lady had a cystoscopy, of course, before. We double stented her. We've opened the bladder. We looked exactly where the nodule is, went around it, excised it, and towards the end, we've closed it off in 2 layers with V-lock. This patient was seen postoperatively. I've seen her recently, actually. This operation was from I think 4 or 5 months ago. She's completely asymptomatic, but the thing to remember is that those patients do need a good follow-up. She had a catheter placed for 2 weeks. She had a cystogram 2 weeks later. She then, after the cystogram was normal, her catheter was removed and the stents were taken out. So on that note, I think I'm right on time. I would like to take this opportunity to invite you to our journal club that happens every month at 6 p.m. UK time. You can look us up on Facebook if you want. And of course, I would like to invite you to Belfast for next year's BSGE. Thank you very much, and I welcome any questions.
Thank you, sir, for your presentation. Your work is quite impressive. But we have always wondering, after this complete structure surgery, do you need to keep your patient on some hormones after this surgery or not?
Sorry, just repeat the question again.
Yes, after this complete surgery, does the disease come back or not?
Well, $1 million question, right? Probably in about 10 to 20%, I would say. Okay, we currently don't have the data for ourselves that says that. Horace Roman recently published his recurrence rate, which is roughly about 10 to 20%. That's what I quote to my patients. I think the most important thing is to excise the disease completely. Whether there's some missed disease that grew back or regrowth of disease is, I think at this stage, impossible to say. But I roughly would say around 20%.
Okay, when it's back, we will do another surgery or we'll try hormonal therapy for them?
It really depends on the patient's symptoms, I think. I think you need to individualize the care. Yes, it's easier to try hormonal treatment first, but you need to, I'm certainly very aware of patients not wanting to be on hormones. And by the end of the day, we need to respect what they want to.
Okay, thank you, sir. Thank you very much. Any questions?
Thank you, Michael. Very nice videos, and thanks, Vasilius, as well. I wanted to ask you about patients who are complaining mainly of deep pelvic pain. Do you do any investigation to diagnose if there is involvement of the sacral roots? And do you have any neuro treatment for these conditions?
So yes, so both Mr. Miras and I have interest in neuropelviology, as you know. It really depends on the symptoms. Then there's this process of neurological examination, seeing if there's any correspondence to the dermatomal redistribution, if there's any motor function that those patients have. We do neuro MRIs, neuro protocols MRIs, to see if there's other vascular compression, neurovascular conflict, or even in fact is the endometriosis growing on the sacral nerve with sciatic lumbosacral trauma.
So what do you do if you have involvement of the nerve, especially S2, 3, 4? What do you usually do? You do surgical treatment as well?
If there is confirmed endometriosis, we would try to excise it, yes.
Thank you. Thank you.
One question by Dr. Hassan Awad.
Excuse me, in the very difficult cases complaining of severe pain, incapacitating pain, and you had performed such high level of surgery, do you resort in some cases to radical surgery, expirative hysterectomy and oophorectomy? Or?
Well, so I come from a school of thinking where we should be only removing what's abnormal. I think personally, that's my personal view, I think doing a hysterectomy on a normal uterus without any confirmation of adenomyosis is probably not necessary. Of course, if there's adenomyosis on ultrasound scan, on MRI scans, then by all means, yes. If you've got an older generation of patients with bilateral endometriomas that are in the late 40s, it's worth discussing removing the ovaries at the same time.
But in the young patients, you don't resort to this?
No, I personally wouldn't. No.
Thank you very much for the nice presentation as usual. And now we will move to the next topic, Mercilon, a new contraceptive tool for a variety of women, Dr. Ayman Abu Noor.
Hi. Okay, Bismillahirrahmanirrahim. Now this is a sponsored session on behalf of Organon, and we'll be talking about a low-dose combined pill, Mercilon. Now, Mercilon. Now, Mercilon is desogestrel, which is a third-generation progestin with a low dose of ethinyl estradiol, 20 micrograms. Now, let's look at this case. A 22-year-old is intending on marriage after 3 months. She wants effective contraception. What is her best option? Now, if we would explore these options, we would find that COCs are the best. It's not logical to give her injectable contraception, which would take a long time. It's not very logical to recommend condoms or fertility awareness methods because she's recently married. COCs is good. It gives good autonomy. She can stop it whenever she wants. Now, she wants a pill with the lowest estrogen possible, and we get a lot of requests with that. Doctor, I don't want a lot of hormones. I want the lowest hormone possible. We used to say high-dose pills contain 50 micrograms of ethinyl estradiol, and low-dose pills were 30. There are no longer 50 microgram ethinyl estradiol, so we say the regular dose is 30, a low dose is 20, and a very low dose is less than 20. We don't have very low dose pills in Egypt because they don't give good cycle control, so we want to give her the typical 30 microgram ethanol pill or a 20 microgram or less than 20. What we would give is the 20 microgram pill. We only have 2 20 microgram pills in Egypt, so we're going to be talking about Mercilon. Why Mercilon? Okay. Now, is the failure rate higher for the 20 microgram pill compared to the 30 microgram pill, and what would you recommend? Now, one of the things that doctors think about, if I give a low dose pill, then we'll have a higher failure rate. Actually, this is not really the case, because once the pill has a lower dose, the side effects are lower. So the compliance is better. So the risk of missing a pill is lower. So the low dose gives equal or comparable results. بيدينا نتائج تقريبا هي. Alright? ليه؟ لأن العينة مبسوطة. فلما تكون مبسوطة مش هتنسى إقراص بسهولة. طيب, healthy non-smoking 40-year-old is fed up with the copper IUD and wants to use a combined pill. Would you give her Mercilon? We used to say that كنا بنقول زمان ما فيش حد بعد ال 40 ياخد إقراص. دلوقتي لا, بندي إقراص. طيب, she's after 40, she doesn't want a lot of hormones. So it's very good to give her a low dose pill. Okay? What about the effects on blood pressure, lipid, coagulation, and glucose? طب أنا الضغط, coagulation. These are the things we're scared about. Now let's take a look at this. When we give only 20 micrograms of ethinyl estradiol, it is insufficient to affect glucose levels. So even if she's diabetic, or she's pre-diabetic, or she's on treatment, probably nothing will happen. Now, triglycerides and HDL cholesterol increase. So the increase in the HDL cholesterol will offset the bad effects on triglyceride. So we are increasing HDL cholesterol, which is the good cholesterol. يبقى نقول إن الشرايين هتبقى أحسن, مش هتبقى أوحش. Next, the effect on renin substrate is insufficient to affect the patient. So the liability to hypertension is low. لأن إحنا عارفين الراس من الحمل بتزود الرينين substrate, فممكن تزود الانجيوتنسين. هنا بالنسبه لنا الايفكت از تو لو انه ياثر، فده عز الطلب للناس اللي عندهم اللي ممكن ضغطهم يعلى بسهوله. اخيرا, it does not reduce antithrombin 3, it does not reduce protein S, and this is very good. يبقى the thrombogenic action is almost non-existent. يبقى these have the least liability to cause venous thromboembolism, بالذات لو العانه مليانه او ما بتتحركش عندها varicose veins او الحاجات دي. How long can we continue? We continue till 50. Low dose pills, 20 micrograms of ethinyl estradiol is equal to 2 milligrams of estradiol valerate, which is the dose in the hormone replacement. يبقى كأننا بنديها ايه؟ hormone replacement. يبقى احنا ضربنا عصفورين بحجر واحد. هنعديها climacteric symptoms, الفترة climacteric, وفي نفس الوقت هنديها منع حمل. لأن الناس اللي سايكلوبروجينوفا is not a contraceptive. تمام ولا لا؟ فاحنا هنقول ان احنا هنا هندي عصفور. يبقى الناس الكبار في السن it's very ideal بالنسبه لهم. اوكي. نبص على البروجسترون. Desogestrel alone has 98.75 inhibition of ovulation. يبقى actually we can give desogestrel وده هيبقى enough كcontraception. So why do we add ethinyl estradiol? Desogestrel اللي احنا عارفين ان هو بالذات blocks ovulation. So why do we add the 20 micrograms? The lack of estrogen بيوحش النفسية. يبقى this is better لنفسية العيانة. Number one. نمرة 2, it potentiates the action of desogestrel, فأقدر أوقف 7 أيام. لما بدي الديزوجسترل لوحده لازم أكمل طول الوقت. واخيرا بيديني better cycle control. يبقى اذا انا الديزوجسترل لوحده is enough for contraception، لكن ايستروجين بيحسن الاكشن فاقدر اوقف 7 ايام وبيحسن السايكل كنترول وبيقلل السايد افكتس. اوكي. طيب يبقى development of the pill الاول we reduce the estrogen dose, we stopped on 30, we now have reduced to 20. We have reduced the progestin dose and we have got selective progestins ملهاش androgenic side effects. يبقى احنا عايزين نمنع الاندروجينيك سايد افكتس acne, hirsutism, depression, headache وweight gain. Okay. البروجسترون ديزوجسترel has strong progestogenic activity, low androgenic activity, low incidence of side effects with minimal changes of the metabolism اللي موجوده عندي. طيب الميرثيلون اهو بندي 21 days and 7 days. يبقى بتديني ميزه عن الديزوجسترل only pill ان انا اقدر اوقف 7 days. حاجه ثانيه فيها ايستروجين. الحاجه الثالثه ان احنا الفاعليه هتبقى اعلى لان احنا عارفين لو انا هدي ديزوجسترل لوحده الويندو بتاعتي is only 12 hours ان انا انسى، لكن هنا اقدر ادي 24 ل 48 hours ان انا اقدر انسى. اللي بعده نيجي بقى الاوفيوليشن سبريشن. هنلاقي ان الاوفيوليشن سبريشن is very good. ovulation suppression is very good اللي هو هنا وهنا الناحيين كويس. next الcontraceptive efficacy. لو احنا بصينا على الcontraceptive efficacy البيرل index is 0.2 قريب قوي من الاذر combined pills. يبقى اذا الcontraceptive efficacy is close to the others. يبقى اذا الخوف بتاعنا كان انه يعمل سبوتنج والخوف بتاعنا الثاني انه يبقى الفعاليه بتاعته تبقى اقل. الكلام ده ما هواش مظبوط. next irregular bleeding. احنا عندنا جرعه الهرمون قليله فانا خايف من irregular bleeding. irregular bleeding في first few cycles up to 20%. then it gradually reduces to below 10%. يبقى احنا لو حصل irregular bleeding عشان الهرمون قليل what is the main treatment؟ reassure the patient ان احنا eventually معظم الحالات دي هتروح لوحدها. كويس؟ ان خلال الكام شهر الاولانيين common فيها irregular bleeding لكن الكلام ده هيتحسن بعد شوي. طيب. next cycle control. كلنا عارفين combined pills one of the main advantages of combined pills انها بتعمل reduction of menstrual bleeding. هنلاقي هنا اهو ناخد بالنا. The amount of bleeding decreased in 23%, increased in 4%. يبقى generally the amount of bleeding is normal or decreased. على بال ما نوصل later on the amount of bleeding على third أو sixth cycle بيقل جدا جدا. يبقى هنقول لها if the patient has irregular bleeding we expect the bleeding to improve وكمان كميته هتبقى ايه؟ أقل. كل ده باللو دوز بيل بسايد افكتس قليله بمينيمال افكت على الميتابوليك بارامترز الموجوده. اوكي ديسمينوريا. السيفير ديسمينوريا بعد 6 شهور is almost non-existent. المودريت ديسمينوريا بيقل من 45% الى 11%. يبقى اذا we can use it كاكسترا benefit انه لا البين مع البيريود هيبتدي ايه؟ يقل. تمام؟ بالذات لو العينه متضايقه. لو سيفير بين السيفير بين هيروح، لو مودريت بين هيحصل له ماركت امبروفمنت. يبقى انا عندي سايكل كنترول از جود at least 90%، bleeding هيقل at least 50%، وعندنا الديسمينوريا هيبقى قليل. premenstrual syndrome هيقل من 20% الى around 10%. يبقى اذا السيمبتومز بتاعت البريمنسترال سيندروم، واللي احنا عارفين ان البريمنسترال سيندروم بالذات لو premenstrual dysphoric disorder before you have to start SNRIs you should probably start combined pills. يبقى لو احنا عندها severe premenstrual dysphoric disorder الحل بتاعها ممكن ندي cyclic SNRIs، ممكن تدي افكسور، ممكن لو عايز هتلاقي ان الدنيا هتبقى احسن، ممكن تدي دولاكسيتين، لكن ممكن العيانه اللي مش عايزه تاخد حاجات سايكوتروبيك ممكن نجرب ان احنا ندي في الاول combined pills، هنلاقي ان البريمنسترال سيندروم بيتحسن. طيب ديسمينوريا قلناها دي خلاص. سوري. اوكي subjective side effects ده مهم. nausea, headache, breast tension. ناخد بالنا nausea may increase في اول شهر او 2، على 6 شهور بتبقى minimal. headache may increase slightly في الاول، بعد كده بتقل اقل من البيس لاين، ده البيس لاين. breast tension بيبتدي يقل. كويس؟ يبقى احنا عندنا الماينور سايد افكتس بتقل below the baseline اللي كانت العيانه عليه، بس ممكن يحصل transient increase في الاول ثم نتحسن. فالعيانه لا في اول شهر او 2 لغايه ما تتعودي ممكن تحسي ببعض الحاجات البسيطه هتروح، مش بس هتروح وهتبقى احسن من الاول. body weight ناخد بالنا الجرعه بتاعت الهرمون is low 20 micrograms only and the progesterone is non-androgenic، فالغالبيه العظمى هيبقى عندهم stable body weight. stable body weight. few patients will lose weight and few patients will increase in weight. will increase around 2 to 3 kilograms. تمام ولا لا؟ يبقى إذن this pill بالذات هرمونز قليلة الويت جين فيها is minimal. هنقول لها جزء من العينين هيخسوا، جزء قليل هيزيد، الغالبية العظمى الويت هيفضل زي ما هو. نوزيا هنلاقي النوزيا مع الوقت بيقل. نوزيا مع الوقت بيقل اللي هو كده. اوكي acne and seborrhea. كلنا عارفين دلوقتي we are now using combined pills for the treatment of acne, either as a treatment or as an adjunctive treatment. اي دكتور جلديه شاطر وهو بيعالج اكني وهيرشوتيزم بيبعتها لك بالمره. الدواء الاساسي اللي احنا بنحب نستعمله هو فيناستيرايد بروسكار، بس عيب الفيناستيرايد انه ممنوع نحمل واحنا عليه، فبندي معاه كومبايند بيلز. يبقى اذا الاحسن هندي كومبايند بيلز. لقينا ايه؟ ان الاكني لوحده بيتحسن والسيبوريه بيتحسن، لدرجه ان في روسيا زمان كان عندهم حظر يستوردوا اي حاجه من الغرب، كانوا بيهربوا راس منع الحمل لمعالجه الاكني في الحالات الستات عندهم. اكني زي ما قلنا بيبتدي يقل، بنستعمله adjunctive مع الفيناستيرايد ومع الايزوترينيتوين. طيب نبص على دي بقى الهيموستاسيس. ادي الميرسلون وادي الريجولار مارفيلون. الدي دايمر is less. كويس؟ الانتي ثرومبين 3 is not affected. بروتين سي بروتين اس not affected. يبقى احنا عندنا التأثير على الكواجوليشن سيستم is minimal. تمام ولا لا؟ يبقى اذا النوع ده لو العينه عايزه بالذات تيك كير، التأثير بتاع الفورث جنريشن اعلى من الثيرد، والثيرد اعلى من السكند. تمام ولا لا؟ لان الاندروجينز ضد الكواجوليشن، لكن احنا عندنا هنا بنلاقي التأثير قليل جدا عشان جرعه الهرمون هتبقى قليله. طيب ناخد بالنا ريلاتيف ريسك في الفينا ثرومبو امبوليزم. الكومبايند بيلز بيحصل 3 اضعاف. فيرست جنريشن 8.5، ده السكند 2.9، الثيرد اعلى، لكن لو بصينا هنا it's only 1.6. يبقى اذا الريسك بتاع الثرومبوزيس is much lower than the general. الجنرال 3 times the normal او 2.9، هنا only 1.6. فاذا العينين الكبار اللي انت خايف عليهم او هي خايفه زياده، طبعا لو انا عندها ريسك فاكتور مش هينفع تاخد، لكن في الحالات دي. اوكي. اللي بعده ليبيد بارامترز. الهاي دنسيتي لايبوبروتين بيزيد واللو دنسيتي بيقل، يبقى دول اكشولي بروتكتيف للارتريز. تمام ولا لا؟ يبقى دول كويسين للارتريز. دي ليه؟ اللي وحش للارتريز البروجستين، بس البروجستين هنا not affecting قوي، فالايستروجين هو الاساس. يبقى احنا هنقول ان التاثير على الهارت او على الفيسلز هيبقى قليل. كويس؟ وده عندنا المايوكارديال انفاركشن هنلاقي ان اقل بكتير قوي ريسك اوف مايوكارديال انفاركشن عن الناس الثانيه. طيب satisfaction بنلاقي ان huge amount of satisfaction بالذات لما نوصل لسايكل نمبر 6. بنلاقي more than 90% satisfaction will not satisfied بيبقوا قليلين جدا جدا. يبقى اذا this pill very low estrogen بس enough انه يمينتين ان النفسيه كويسه، enough انه يحسن كل الحاجات النون كونتراسبتيف، ونوع البروجستين لوحده is a strong contraceptive ومالوش سايد افكتس كتير. اوكي؟ نيجي بقى المود والفيزيكال هيلث والورك، هنلاقي ان كل الحاجات دي بتتحسن. اللي انا حاسه ان الفيزيكال هيلث بتاعها احسن اهو، اللي انا حاسه ان المود بتاعها احسن، حاسه انها بتقدر تشتغل احسن. اوكي؟ ده التشينج ان لايف سكورز. هنلاقي ايه؟ ان بيفور ستارت هنا اللايف سكور كله بيزق ناحيه ذا بيتر، ناحيه ذا بيتر. اوكي، يبقى مره ثانيه لو احنا بصينا على النون كونتراسبتيف بنفيتس المختلفه، البليدنج بيتحسن وكان يوز ثيرابيوتيك ولو ان التحسن مش جامد قوي. ديسمنوريا definitely تتحسن بالذات لو سيفير. بريمنسل سيندروم improves بتقل باي من 25 ل 10%. اندروجينز ممكن نستعمله ثيرابيوتيك مع حاجات ثانيه. اوفيريان سيس مش هتحسن. بي اي دي هيقل زي اي بيلز. بون دنسي 20 micrograms of estrogen will always maintain bone density. لان احنا بندي في الهرمون ريبليسمنت 2 milligrams of estradiol valerate اللي هي equal ل 20 micrograms of ethanol estradiol. ليه افكت على الاندوميتريوزس، بيمنع ovarian cancer, endometrial cancer and colon cancer اللي هي زي اي combined pills. تمام؟ فاذا كل دي benefits موجوده عندي. Conclusion: ميرسلون ليه excellent reliability comparable الحاجات الثانيه، excellent cycle control, withdrawal bleeding عادة أقل، side effects قليلة جدا، effect على البودي ويت قليل، satisfaction كويس، الريسك بتاعنا زي second generation take care، زي ما قلنا الفي تي الفينس ثرومبومبوليزم السكند احسن من الثيرد احسن من الفورث، بس السكند از اندروجينيك، فانا اديت حاجه نون اندروجينيك وليه نفس الايه اللو سايد افكتس بتاعت السكند في الفينس ثرومبومبوليزم، مايوكارديال انفاركشن ملوش زياده في الريسك وفيه كل الهرمونال بنفيتس. اشكركم مره ثانيه على الاستماع. I have 2 minutes left. لو حد has a question I have 2 minutes. Okay. Okay. Thank you.
Professor Ayman, any questions?
تفضل.
less androgenic effect هو نفسه كان الجاينيرا قبل كده ولا غيره؟
No. الجينيرا is 30 microgram pill واللي بنستعمل جستودين. This is desogestrel. الديزوجستريل ميزته عن الجستودين انه الباور بتاعه كcontraceptive efficacy is very high. حتى عشان كده السيرازات بيستخدم ديزوجستريل only. تمام؟ فليه الcontraceptive power is very high. فبندي جرعه اقل. تاني حاجه ده 20 micrograms of ethinyl estradiol مش 30. It's still a third generation pill بس ليها بعض الحاجات ان قدرت انزل بالايستروجين لان الباور بتاع الديزوجستريل is very high.
less androgenic effect isn't it harmful as regards انت حضرتك قلت ال benefits ال unbenefits او misunderstanding اللي حصل عندنا ان less androgenic effect بيعمل less libido effect.
كويس. This is an excellent question. هل combined pills اللي هي anti androgenic بيقللوا الليبيدو؟ Actually no. لأن المين inhibitor of libido is the fear of pregnancy. تمام؟ اللي بيخلي الواحدة خايفة يحصل intercourse أو مش عايزة intercourse is the fear of pregnancy. فإذا if I remove the fear of pregnancy usually that will increase the libido.
It's not the androgenic effect which is decreased in these pills. It is not responsible for libido decrease. Because many patients, many clients came to me complaining of decreased libido after using this third generation.
Yes, but احنا we have to look at الحاجات التانية. ان احنا دلوقتي العانة كبرت، عندها عيال بيصرخوا، جوزها بيجي تعبان، هي بتيجي تعبانة، فالليبيدو إيه لو انت عايز تغير اوكي. السكند جنريشن دلوقتي مش موجود في السوق الا في وحدات الصحة لان بيقف على الدولة ب6 جنيه. لدرجه ان الوحدات الصحيه ما عدناش بننزل second generation pills لان العيانين متضايقين انه بياخدوا حاجه inferior. يعني العيانين بقوا متضايقين.
Thank you, Professor Ayman.
Thank you.
Great pleasure. Our next speaker is Professor Abdulatif Al-Khouli. He's going to talk about the tips and tricks from the experts of successful insertion of implanon.
صباح الخير. ثانك يو مستر تشيرمان. تكملة لمحاضرة دكتور أيمن هنكمل جزء تاني برضو على الكونتراسبشن و this talk is sponsored by Organon Egypt وهنتكلم على نفس الجزء بتاع البروجسترون اللي الدكتور ايمن لسه متكلم عليه اللي هو الديزوجسترال. احنا المحاضره تتقسم جزئين. الجزء الاولاني هيبقى كلام على الامبلانون كميثود اوف كونتراسبشن وفي الاخر في شورت فيديو على الانسيرشن والريموفل تمهيدا للورك شوب اللي يحب يحضره في النكست هول. طبعا الكونتنت انا حاولت اراعي ان هو يبقى as updated as possible اخره يعني 2023. الكونسبت بتاع اللارك او لونج اكتنج ريفرسبل كونتراسبشن كان الى حد كبير حاجه الناس بتخاف تقرب منها لانها كانت بتخاف من الريفرسبيليتي، تخاف ان هو الكونسبت اللي كان مسيطر على الناس ان حقن منع الحمل ممكن تعمل عقم وممكن تاخر البيريد بعدها up to 18 months وانها ممكن تعمل انفيرتيليتي، خصوصا ان اللونج اكتنج دول الهرمونال معظمهم كان تداولهم شبه قاصر على مراكز الصحه، ما كانوش متداولين في البرايفت براكتس كتير، فالناس كانت معتبر ان ده ناشونال بروجرام وبالتالي مش هنستخدمه في العيادات بتاعتنا. الكونسبت تاني حصل له ريفايفر بتاع اللونج اكتنج ريفرسبل كونتراسبتيفز، وهي عباره عن الحاجات اللي بنستخدمها اقل من مره في الشهر او اقل من مره في السايكل، زي الاي دي وذر الكوبر اي دي او الليفونورجسترال انترا سيستم او الانجكتبل بروجستيرنز اللي هي كل 3 شهور او الامبلانتس اللي هو الموضوع بتاعنا النهارده. الامبلانون عباره عن ايه؟ الامبلانون عباره عن نفس السترونج كونتراسبتيف اللي دكتور ايمن لسه متكلم عليه اللي هو الديزوجسترال، one of the most potent progesterones كايفكت على السبريشن بتاع الاوفيليشن. ذاتس واي ان هو اتحط كسول كونتراسبتيف في بعض انواع البيلز. الامبلانون عباره عن رد 4 سم في 2 مللي، المفروض ان هي بتتحط سبديرمالي وبتشتغل بسيفرال ميكانيزمز combined all together to prevent pregnancy. الامبلانون الفكره المتعارف عليه انه بيقعد فتره طويله، ان هو ممكن يبقى ستورد، او دي الفكره اللي عند بعض الناس. الحقيقه ان التكنولوجي اللي في الامبلانون ان هو داي تو داي ريليز، يعني الامبلانون از فيري رابيدلي ابزورب، بيوصل تقريبا بعد 24 ساعه من اول انسيرشن الى البلاد ليفل اللي ممكن يسبرس اوفيليشن. هو الليفل بتاعه المفروض يبقى 90 بيكو جرام بير مليليتر عشان يسبرس اوفيليشن، وده تقريبا بيبقى ريتشد في الفيرست داي. ذاتس واي لو هو انسرتد لغايه 5 يوم البيريد you don't need to cover up by any additional method of contraception. الليفل بتاعه بيوصل البيك بتاعه بعد 5-6 اسابيع، وبعدين على اخر السنه الاولى بيبقى حوالي 35 ل 45، تاني سنه بينزل حوالي 5، تالت سنه اخرها بينزل حوالي 5. وبعد كده بينزل قد ايه؟ وهل ممكن الامبلانون بعد كده يبقى ستيل اكتف؟ وهل هو ممكن يبقى له فيرذر كونتراسبتيف افكت؟ الكلام ده طبعا يعني خارج الصندوق، ما ينفعش يتقال بصوره رسميه. المفروض ان هو لو ريت ليميتنج ممبرين هي اللي بتخلي المايكرو كريستلز بتاعه الايتونوجسترال اللي موجوده جوه الرد ان هي تخرج بريت معين عن طريق الايفا ممبرين كل يوم، بمعدل بيقل تدريجيا لغايه نهايه السنه الثالثه، وبعدين بيثبت شويه بعد كده. بيشتغل ازاي الامبلانون كلونج اكتنج ريفرسبل كونتراسبتيف؟ هو بيشتغل بطريقتين. الطريقه الاولى بتاعته هي السبريشن بتاع الاوفيليشن، يعني هو شكله بيشتغل زيه زي الديزوجسترال اللي موجود كبروجستين اونلي اورال كونتراسبتيف. الحاجه الثانيه ان هو طبعا الايفكت بتاعه على السيرفايكال ميوكس، مش قوي على الاندوميتريال ريسبتيفيتي، لكن برضه بيأثر على التيوبال موتيليتي. والدول ميكانيزم اوف اكشن هو ده اللي بيبوش الفتره اللي بيشتغلها الامبلانون sometimes behind المده بتاعته، لان هو حتى لو السبريشن اوف اوفيليشن ايفكت ابتدى يقل بنهايه السنه الثالثه، لكن ستيل البروجسترون بيبقى كافي تو make a hostile cervical mucus. One of the highest success rates، يعني محطوط equivalent للفازكتومي وللتيوبال اوكلوجن كافيشنسي، يعني تقريبا بيقولوا اول سنه اقل من 0.0500 women year، وده تقريبا اقل حاجه في الكونتراسبتيفز. التطور بتاع الامبلانون كان تطور يسهل قوي عمليه استخدامه كاوت بيشنت. ابتدى بالنور بلانت الاول اللي هو كان زي فان شيب 6 رودز بتتحط، وابتدى بعد كده يبقى سنجل رود اللي هو الايتونوجسترال الامبلانون لوحده، وبعدين بقى النيو تكنيك اللي هو الامبلانون نكست، وبقى له سبيشال انتروديوسر. والسبيشال انتروديوسر ده هتشوفوا حضراتكم هو بيحمي من الديب انسرشن ازاي. الميزه الاساسيه ان هو بقى راديو اوبيك، مش محتاج هاي تك راديولوجي ايمجنج عشان يبينوا، الترا ساوند بيبينوا، سي تي، ام ار اي، اكس راي بيبان بسهوله. ده في حاله اذا حصل inadvertently a deep insertion. الليفل بتاعه زي ما قلت لحضراتكم هو تقريبا بيبقى ستيبل لغايه ال3 سنين بتاع الاستخدام. واميزنجلي ايفن في الناس اللي عندها هاي بادي ماس اندكس، اللي بنخاف ساعات يبقى الاذر هرمونال كونتراسبتيفز مش كافيه بالنسبه لهم، الحقيقه ان الامبلانون ايفن في الهاي بادي ماس اندكس بيبقى برضه ستيل البلاد ليفل بتاعه لقوا ان هو اعلى بشويتين 3 من ال 90 بيكو جرام مليليتر اللي هو محتاجينهم. طيب الامبلانون وضعه ايه كلونج اكتنج ريفرسبل كونتراسبتيف؟ يعني ما نيجي نقارنه ببقيه الحاجات، ايه الحاجات اللي احنا السيلينج بوينتس اللي احنا ممكن نفكر فيها، وهنشوف بعد شويه كمان الدروباكس اللي هي لازم نوصلها للبيشنت عشان البيشنت اكسبتنس بتزيد كل ما انا شرحت وعملت جود كونسلنج للبيشنت. يعني لو انا ما وضحتش سايد افكتس كويس ديفينتلي العيانه هتيجي بعد كده تطلب ان احنا نشيلها. فلو قارناه طبعا هو بروجستين اونلي كونتراسبتيف، والميزه بتاعته ان هو بيتجنب الاستروجين وبيتجنب كل الكونترا انديكيشنز بتاعت الاستروجين، وعلى رايها طبعا البريست والثرومبو امبوليك ديزيزز. كمقارنه بالبروجستين اونلي كونتراسبتيفز طبعا هو مش معتمد على الدي تو دي يوز بتاعت البيشنت، نسيت النهارده افتكرت بكره، كده كده هو لونج اكتنج ميثود. ثالث حاجه هو طبعا ما بيعملش البون ايفكت والاوستيوبروزس زي الديبوميدروكسي بروجسترون اسيتيت، وبيسايدز ان هو كمان بيساعد ان هو الافشنسي بتاعته تبقى عاليه حتى في الناس اللي عندها بادي ماس اندكس. والريفرسابيلتي ودي حاجه ممكن تكون الناس مش واخده بالها منها، هو اتس فيري رابيدلي ريفرسبل، يعني كونسبت ان هو اول ما بيتشال الليفل بتاعه بيقل دراماتيكالي وبيبقى البلاد ليفل بتاعه اولموست مش موجود في السيركوليشن، is not biochemically detectable after 7 days of removal. other non-contraceptive benefits بيقلل طبعا بصفته بروجستيرون، بيقلل شويه الناس اللي عندها شكوى الديسمينوريا مع الاندومتريوزس، وكمان بيساعدنا في العيانين اللي هم عندهم بي سي او، لان البي سي او طبعا مشاكلهم الست اللي مش عايزه تحمل ساعات تيجي تقول انا عايزه اركب لوب، هتركب لوب مثلا كوبر اي دي، كده كده هتبقى عندها ابيسودز اوف اوليجومينوريا، وطبعا ده بيعرض الاندوميتريوم لبرولونجد انوبوز استروجين والمخاطر بتاعه الاندوميتريو هايبربليزيا ليتر اون. فطبعا هو ده بيوفر لي بروجستيرون هو وبقيه البروجستيرون اونلي كونتراسبتيفز يخلي لي الاندوميتريوم الى حد ما في حاله سيف في خلال الفتره العيانه مش عايزه الحمل فيها. وطبعا ما ننساش انه بصفته هرمونال فديفنتلي الانزيم انديوسرز اللي بتشتغل على السيتوكروم بي 450 مثلا انتي ايبيلابتكس ديفنتلي بتقلل الفعاليه بتاعته شويه. طيب ايه بقى السايد افكتس اللي انا محتاج ان انا اوصلها للبيشنت عشان تقدر ان هي تتقبل الوسيله او ترفضها لو هي مش متقبلاها؟ اللوكال سايت رياكشنز دي حاجات سهله وبسيطه قوي، واحب اقول لحضراتكم هي كتير منها بتحصل نتيجه للاوفر انثوسيازم during the insertion. يعني طبعا ممكن يبقى فيه شويه بين ات ذا سايت اوف انشكشن، شويه بروزس، وجع شويه، وده غالبا بيروح في خلال يومين ثلاثه. الافراط في ان انا مش عايز العينه تحس خالص، الافراط في اللوكال انستاتيك اللي بيتاخد بيخلي العينه طبعا بيبقى فيها تيشو اكسترافازيشن كتير، يبقى فيها بروزنج ودي العينه تزرق او ترجع تشتكي منها ونقعد نديها انتي انفلاماتوري. فبرضه وي شود بي فيري انثوسياستيك في اللوكال انستاتيك الكميه بتاعته during انسرشن. السيستميك سايد افكت الاساسي اللي البيشنت شود بي فيري ويل كونسلد هو التشينج في البليدنج باترن بتاعها. لازم العيانه تعرف انها مش هتشوف الدوره زي ما هي كانت متعوده عليها، علشان ما تجيش بعد 3 4 شهور تقول انا البيريود ملخبطه فانا عايزه اشيل الكبسوله. وهنتكلم على الاذر افكتس. التغير اللي بيحصل في الباترن بتاع البيريود بيبقى اقصى ما يكون في الفتره الاولى بعد الانسيرشن، وبيبتدي يتحسن يوجولي بعد اول 3 شهور. الوضع اللي هيوصل اخر السنه الاولى غالبا هو الوضع اللي هيستمر بالبيشنت بعد كده، وهو غالبا بيبقى متقسمين خمس 3 اخماس. خمس بيجي لهم اولموست امينوريا، خمس بيبقى عندهم فريكوينت ابيسودز اوف بليدنج بيبقوا متضايقين، والثلاث اخماس بيجي لهم سم irregularity بس التوتال ابيسودز اوف بليدنج بتبقى ايكويفالنت او اقل لليوجوال سايكلز بتاعت العيانه. لو جمعنا كميه الدم اللي بتنزلها في 3 شهور تقريبا هتبقى هي في حوالي 60% من البيشنت، يعني هيتبقى 20% هيبقى عندهم مشكله من الشكوى بتاعته. طيب واذا ده حصل ايه الوسائل اللي احنا ممكن نتعامل بيها؟ طبعا اول حاجه لازم اكون عامل جود كونسلنج في الاول وري اشورنج ذا بيشنت، دي حاجه طبيعيه. والوسائل المتاحه ممكن ندي ترانكزاميك اسيد، ممكن ندي انتي بروستاجلاند زي الميفيناميك اسيد، ممكن ندي كومبايند بيلز وذر سيكونشال او كونتينيوس لمده 3 شهور كومبايند اورال كونتراسبتيف بيلز، او ممكن نديها النور اثيستيرون سايكليك 3 ويكس ونريح وناخد 3 ويكس كمان، على اساس ان هي تساعد على اللي يبقى اندوميتريوم يوصل لمرحله الديسيدولازيشن بدري شويه. البون افكت، الفاكولتي اوف سكشوال اند ريبرودكتيف هيلث كير اكبر جهه في انجلترا تقريبا بتدي ريكومنديشنز امندد في 2023 ان شي كود نوت الوكيت اوستيوبروزس للامبلانون مهما كان بيعمل شويه هايبو استروجينيك اكشن، بس اتس نوت ات اول كومباربل بالانجكتبلز اللي بتتاخد الديبو ميدروكسي بروجسترون اسيتيت. ملوش significant effect although حتى لو غير شويه في البروفايل، لكن ملوش significant effect on the insulin and lipid metabolism. طبعا هو بيتجنب الاستروجين يوز ك كونترا انديكيشن طبعا في حالات الفينس ثرومبو امبوليزم. اذر بروجستيشنال سايد افكتس اللي ممكن تحصل من حد للتاني بدرجات متفاوته، زي شويه بلوتنج، تندرنس، بي ام اسنج، شويه ويت جين، ويوجولي بيحصل له tolerance. These information should be counseled to the patient before الانسرشن. طيب لو انا العيانه جايه دلوقتي قلقانه، ده لونج اكتنج، يعني انا معنى كده ان انا ما هشيله هفضل فتره مش عارف احمل، اصل قريبتي خدت الحقنه وفضلت بعديها شهرين 3 4 ما بيجيش بيريد. الحقيقه زي ما اتفقنا بعد اسبوع بيبقى البلاد ليفل ان ديتكتبل. 90% من الناس اللي بتريموف بتريزيوم اوفيليشن within 3 to 4 weeks اللي هي النسبه الطبيعيه العاديه جدا. بنركبه امتى؟ بنركبه في الميعاد اللي كنا هنستخدم فيه الوسيله العاديه، يعني لو العيانه جايه تركبه من غير اي بريفيس كونتراسبشن بنركبه في اول 5 ايام من البيريد. لو العيانه جايه سويتشر لكومبايند كونتراسبشن بنركبه اول ما بنوقف الوسيله الثانيه، يعني مثلا خلصت علبه الكومبايند بيلز النهارده بركب بكره، وبالكتير في ميعاد العلبه الجايه اللي هو بعد الاسبوع الراحه. بس طبعا اريح لي ان انا اركبه وانس توقف الوسيله الثانيه، ونفس الكلام ينطبق على الباتشز اللي مش موجوده او الرينج برضو اللي مش ان كومن يوز. لو العيانه دي بتغير من بروجستين اونلي كونتراسبتيفز ممكن طبعا الاورال بناخد في اي وقت خلال الشهر، ما لهاش علاقه بقى بالبيريد، اتس بروجسترون افتر بروجستيرون، فبالتالي ممكن في اي يوم في الشهر في ميعاد الحبايه اروح مركب الامبلانون. لو العيانه بتاخد حقن هاخدها هركب في ميعاد الحقنه اللي جاي، ولو العيانه بتشيل كبسوله وعايزه تركب ممكن اركب في نفس الوقت سيم ارم او كونترالاترال ارم. بعد المسكارج ممكن اركب وقت المسكارج لو فيرست ترايمستريك او في خلال اول 5 ايام، لو سكند ترايمستريك في خلال 3 to 4 weeks. لو العيانه بوست بارتم بركب within 3 to 4 weeks لو هي not breast feeding، بعد 4 اسابيع لو هي breast feeding، ولازم اكفر اب ب 7 days. كونترا انديكيشنز طبعا لو انا شاكك في ابنورمال جينيتال بليدنج ما اعرفش سببه، لو انا عندي شك في حمل، لو انا عندي هرمون سنسيتيف تيومر بالذات لو بريست، لو انا عندي current active liver disease او benign او malignant hepatic tumors، لو انا عندي allergic reaction لاي من الكومبوننتس الموجودين، دي كلها طبعا كونترا انديكيشنز للانسرشن. صوت هيشتغل ولا انا ريت؟ انا صوت هيشتغل هنا ولا؟ ده فيديو كده صغير هناخد حته منه في الانسرشن وحته صغيره في الريموفل. طبعا احنا بنركب 10 سم 8 ل 10 سم فوق الميديال ايبيكوندايل، و10 سم بنيجي للجروف اللي ما بين البايسبس والترايسبس. الجروف ده هو اللي فيه النيوروفاسكولار باندل، ومفروض ما ركبش فيه، مفروض انزل تحتيه من 3 ل 5 سم عشان اتجنب النيوروفاسكولار باندل. هو كده واقف. مفروض طبعا بعمل ده اوت بيشنت بروسيدير، بعمل لوكال ستيرلايزيشن، بحضر. اهم حاجه في الانسرشن والريموفال ان انا ابقى كل التولز ميد ريدي، يعني ما اجيش اقوم واسيب العيانه واجيب من هناك اللوكال وارجع تاني ونسيت البيتاداين وهجيب الشاش المعقم ونسيت الباندج بعديها. لازم كل الحاجات تبقى موجوده على الترابيزه قدامي. احنا الفيديو واقف، وحتى لو هشتغل من غير صوت مش مشكله، انا هكومنت عليه. كده اشتغل تمام. هنكمل كده يعني نظري لغايه ما تطلع الفيديو. المفروض ان العيانه بتركب الامبلانون تبقى كلها بالبابل، اهم حاجه هو السبديرمال انسيرشن، ده بيقلل جدا فرص المايجريشن اللي هي اوريدي فيري رير. ومع النيو انتروديوسر الامبلانول نكس بيبقى صعب جدا انك انت اصلا تخش ديب، لان الانتروديوسر هيخبط في الجلد، انت مش هتعرف تكمل، هو لازم تعدل ايدك فيبقى الانتروديوسر بارلل لسطح الجلد. بنعلم نقطة مكان الانسيرشن اللي احنا اتفقنا عليها، بنعمل ستيرلايزيشن وبعدين بدي لوكال انستاتيك. اللوكال انستاتيك سنتي كفايه جدا، وبديه سبديرمال وبديه الونج التراك اللي هركب فيه، وبعد ما بدي لوكال انستاتيك بستنى لمده دقيقه، وبعد كده ببتدي ان انا احضر الانتروديوسر بتاعي. اهم حاجه الانتروديوسر لازم اتشيك، ابقى شايف الكبسوله موجوده قدامي عشان ما يبقاش وقعت حد فتح قبل كده، يبقى لازم اشوف الكبسوله موجوده بعيني. ولما اشيل الكفر او الكاب بتاعها لازم ما وطيش ايدي ساعتها، لان انا لو وطيت ايدي هتروح الكبسوله واقعه، فلازم ابقى دايما رافع ايدي لغايه ما اجي ان كونتاكت مع البيشنت. احنا اخر خالص بقى، اقلب من عندي ولا تقلب من عندك؟ السلايد اللي قبل الاخيره باتنين. لا قبل دي وقبلها واحده كمان، ممكن تشغل بقى من دقيقه الرابعه، يعني هات على 4 دقايق وشغل بقى الحته الباقيه. طب ممكن تجيب اللي بعديها بتاعت الشيل وبعدين نبقى نشوف التركيب ربنا يحلها. هات اللي بعدها بقى. ممكن نجيب ال 55 ثانية، يعني ممكن نمشيها. طيب نكمل الانسيرشن لغايه ما نشوف موضوع التكنيكاليتيز. ف المفروض ان انا بخش 30 درجه just to puncture the skin، ويبقى التيب اوف ذا نيدل بالكامل دخل تحت الجلد بالظبط. وانس انه دخل التيب اوف ذا نيدل بالكامل تحت الجلد، ببتدي اعدل ايدي وكده كده بنيم الانتروديوسر على السطح بتاع الجلد، وابتدي امشي بارلل. بمشي بارلل وانا ماشي بعمل تنتنج بالتيب بتاع الانتروديوسر للجلد الفوق عشان ابقى داخل سبديرمال، يعني انا بحك في الجلد من تحت وانا عامل انترودكشن، واخد بالي ان انا ما اعملش دبل بانكشر، يعني ما بقاش السن مرفوع قوي عشان ما اعملش دبل بانكشر. طب لو حصل ازمه، لا مش ازمه خالص، هرجع سنتي وابتدي اكمل التراك بتاعي تاني لغايه الاخر خالص، لان بيبقى فيه بوينت اوف ريزيستنس قبل الاخر بسنتي من الرد اللي هي 4 سنتي. البوينت اوف ريزيستنس دي انا بكمل بعدها لغايه ما الهول انتروديوسر بيخش جوه السكن، وساعتها في الفايلت بutton ببوش ات داونوردز اند باكوردز، فبيبتدي يعمل ديسلوجينج للامبلانون كبسول انسايد ذا سبديرمز. بعد ما بشيله بميك شور ان هو طلع فعلا من الانتروديوسر، بشوف الاوبتيريتور اللي لونه فايلت موجود جوه، وبخلي العيانه تحس بايديها تطمن ان الانسيرشن از كوركتلي سبديرمال، وبعدين بعد كده بحط باندج واشيله بعد 24 ساعه. الريموفال سيم ستابس، برضه بدي لوكال انستيزيا، واهم حاجه اخد بالي ان انا بدي اللوكال ادي تحت الكبسوله، يعني انا بزق الكبسوله من ناحيه الاكزيلا ناحيه القلبو عشان اخلي التب بتاعها باين، واخش ادي اللوكال تحت الكبسوله شخصيا، عشان ده هيساعدني انه يرفع لي التب بتاع الكبسوله، وبعدين بالسكالبل هعمل سمول انسيجن على التب واقعد افتح عليها لغايه ما التب بتاع الكبسوله تطلع لي من الجلد، وبعدين اقدر اشدها سهوله بموسكيتو فورسبس. ساعات بتبقى حصل فايبرز باندز حواليها، ساعتها ببتدي ان انا امسكها بموسكيتو فورسبس واقلبها الناحيه الثانيه، بمسكها من الطرف ده واقلبها الناحيه الثانيه، فبتجيب لي حته تحتيها اقدر بالمشط اقطع الفايبرس باند واشد الموسكيتو تاني وراها، واحد يسلم التاني لغايه ما اشيلها خالص. اعتقد ان شاء الله يعني الفيديو يبقى شغال في الورك شوب. تقدر تقدمه على دقيقه، يعني تقدم العداد بتاعه لغايه 55 ثانيه. طبعا ده السايد بتاع الانسيرشن، المفروض ان انا ببقى قادر ان انا ده فايده ده طبعا ان انا ببقى كاتب رايت او ليفت هاند. احنا يوجوالي كلاسيكلي بنحطه في النون دوميننت هاند، لو هي رايت هاند احطه في الناحيه الثانيه، والعينه بتنام وتبقى ايديها ورا راسها او جنب ودنها. ممكن نقدم كده 10 ثواني 20 ثانيه نص دقيقه نقدم المؤشر شويه. طب يعني على الرسمه هو التيب بتاعها بيبقى باين اهو. انا بزق من ناحيه الاكزيلا، التيب اللي هنا بزقه ناحيه القلبو او الكيوبيتال فصه لغايه ما التيب بتاعها يبقى باين، وبعدين بخش باللوكال انستاتيك بروح حقن تحت التيب بتاعها. اما بحقن تحتها ده بيساعد انه يرفعها لفوق شويه، وبعدين بعد كده بعمل عليها الانسيجن زي ما حضراتكم هتشوفوا. just under the tip بتاع الامبلانون. طبعا لو انا حقنت فوقيه هي هتضيع وتبتدي تنزل تحت شويه، يبتدي يحصل ديرمال اديما وهيبقى اصعب شويه الريموفال. ما حقنش كميه كبيره، نص سنتي هيكفي جدا. ساعات مجرد ان انا بعمل سمول انسيجن بالسكالبل، سكالبل 11 عشان يبقى بوزه رفيع، وافتح بس حته واحده على قد التيب بتاع الامبلانون. ساعات مجرد ما افتح الاقي الامبلانون طالعه، بالذات لما بقالهاش فتره طويله يوجوالي ما تبقاش كونت فايبرس باند حواليها. مجرد ما تطلع انا ممكن ازقها بصباعي اللي ورا، او ممكن ان انا ادخل موسكيتو فورسبس امسك التيب بتاعها بيه. ساعات تبقى مستخبيه او عليها فايبرس باند، في الحاله دي ممكن ان انا اعمل سمول انسيجن صغيره اوفر ذا تيب، يعني هي هتبقى متغطيه بحاجه اعمل عليها سمول انسيجنز. طبعا احاول بقدر الامكان ان انا ما امسكش واشد قوي الا لو انا متاكد تماما ان انا ماسكها عشان ما تكسرش مني، والذو ان ده هيبقى صعب شويه. ده الوضع اللي هو لو لقيناها سهله في وشنا. لو لقيناها بقى كفرد باي فايبرس باند، يعني دي اخر حاجه هنمسك حته منها، او حتى لو مسكت الفايبرس شيث وقلبت الموسكيتو الناحيه الثانيه هيبقى معايا الكبسوله قربت مني شويه واقدر افتح عليها بالسكالبل زي الوضع ده بالظبط كده. وباجي بالمشط او بموسكيتو ابتدي اقطع الفايبرس باندز. ممكن امشي along الكبسوله بالمشط كده لغايه ما تطلع معايا. اشكركم جزيلا وشكرا مستر تشيرمان.
شكرا دكتور عبد اللطيف for a very nice presentation.
هستاذن بس حضرتك، هو الورك شوب هيبقى في قاعه ايسلاند. الورك شوب بتاع الانسيرشن والريموفال على مودلز بالفيديوز هيبقى في قاعه ايسلاند دلوقتي على طول.
Now we are presenting Professor Dr. Hatem Al-Gamal and the topic thromboprophylaxis during antenatal and postnatal period. اتفضل يا دكتور حاتم.
Good afternoon. This session is sponsored by Sanofi. الحقيقه يعني انا اتكلمت مع سانوفي لان احنا هنا في عندنا جزئيتين في اليوز اوف ذا فور ثرومبوبروفيلاكسيس الحقيقه. واستخدام الدواء اللي هو اللو موليكولار ويت هيبارين. الحقيقه احنا لما عملنا سيرفي لقينا ان احنا عندنا في مناطق في التخصص فيها ابيوز، احنا بنستخدمها في غير مكانها خالص، وفي اماكن انديكيتد ان انا استخدم فيها الدواء ما بنستخدموش، في حين ان في مناطق تانية بنستخدم الدواء وما فيش اي ايفيدنس في استخدام هذا الدواء، لكن في مناطق تانية مهملة ومهمة جدا هي اللي مفروض ان احنا نركز عليها. طبعا انا عشان الكلام العنوان ثرومبوبروفلاكسيس during antenatal and postnatal stages، فانا راجل يعني بتاع انفيرتيليتي واي في اف اكتر، فدخلنا معاهم البريجننسي مع الاي في اف لان ده هيبقى انديكيشن جامد جدا. Guess who is she? I think this is in Asogic 23. This is Louis Brown. Louis Brown, the first IVF baby, and she was here 3 years ago in our conference. And here is the IVF background, which was invented by Professor Patrick Stiptoe and Professor Edward in 1978, July 1978. That's to say she is now 45 years old. And here her mother when she was pregnant in Lewis Brown, and this is Lewis Brown, non-IVF baby. She delivered twice. She has 2 living females and non-IVF. Unfortunately for those doctors in India, Dr. Subhash and Dr. Sanit, this was also doing IVF parallel with the Stiptoe and Edward, but the first IVF born by those 2 professors was in October 1978, and they are both working independent, but the credit of the procedure go to Patrick Stiptoe and the Professor John Edward, although they do the same thing. كل واحد بقى وحظه وربنا اداهم هم التانيين ودول ما حدش فاكرهم ما حدش عارفهم خالص. Infertility, of course, affects about 10 to 15% of the couples. In vitro fertilization has been rapidly growing as a treatment of choice around the world. Today, approximately more than 5 million babies born with the IVF. Steady increase in the demand of assisted reproduction. 1 in every 6 infertile females will have the need IVF. That's why, because of the in our era of postponing childbearing, this is the era of the independent woman, and she wanted to postpone the childbearing, and it reached to old age. So she may need to do IVF because of these ideas. New medical treatment options for serious illness. This is very important, and that's when we have oncofertility unit in our specialty. Oncofertility, we can preserve the oocytes for them. The growing demand of fertility preservation in women with malignant disease. Anticoagulation and in vitro fertilization. This is very important. This is the areas what we need to use the anticoagulation, not to increase the implantation and not to increase the demand. It has no rule, no evidence of the rule of the use of low ferricinated heparin in case cycles of the IVF to increase the fertilization or to increase the implantation. But there is a good evidence that the complications associated with the assisted reproduction, like the hyperstimulation syndrome, this is very important because venous thromboembolism is increased with in case of the IVF. Ovarian hyperstimulation syndrome in its severe forms is associated with an increase of the risk of the thromboembolism, which may be fatal. IVF is reported to double. IVF per se is double the risk of thromboembolism in pregnancy. That is to say, if the patient got pregnant, we will apply the module she may need. If she got pregnant, she may need to have the thromboprophylaxis, but not to write routine. This is routine Clexane or routine for all patients doing the IVF. Recurrent implantation failure, thrombophilia, which may be associated with increased likelihood of these events, and the overdiagnosis of thrombophilia. I think we have overdiagnosis among a large number of investigations, and the doctor saying these investigations, I'm be sure that most of us didn't know what he see about the thrombophilia's examination. Thrombophilia may be associated with increased likelihood. This is important, but it is overdiagnosed. Although data are limited, antithrombotic therapy is frequently used to enhance the likelihood successful of the assisted reproduction. How does IVF affect the coagulability? In vitro fertilization induced elevated estrogen levels are associated with hypercoagulable state. Maturing follicles lead to increase the estrogen to supraphysiological levels, and this increase in estrogen has been shown to cause the hypercoagulable state. During pregnancy, electromicroscopic study shows that the changes in the platelet and in the fibrin, these morphological changes in platelet and fibrin structures associated with increased estrogen levels, which may be at least partially explain the hypercoagulability that occurs during the IVF. Risk of thromboembolism in pregnancy. The risk of thromboembolism in the first trimester in the IVF, it is increased if it is got pregnant. So I want to stress on this point. We use if the patient got pregnant or if the patient complicated during stimulation by hyperstimulation, but not a routine for every patient in the IVF to write the low molecular weight. The risk of thrombosis in the first trimester in the IVF pregnancy increase about 5 to 10 folds. So she needs to have the low molecular weight, mainly due to up to 100-fold risk in cases of the hyperstimulation syndrome in the IVF, and especially if she had early hyperstimulation and got pregnant and had continued with the late form of hyperstimulation, and this is very risky, very high risk patients to have thromboembolism. This increment is present during the entire first trimester. So if you have a patient and got pregnant and she had a hyperstimulation during the induction and got pregnant, continue with late hyperstimulation, that throughout the first trimester, the 3 months or the 13 weeks of pregnancy, she must receive the prophylactic doses of the Clexane or of the low molecular weight heparin. There is a very high risk of thromboembolism in vitro fertilization complicated by ovarian hyperstimulation syndrome. Thromboprophylaxis is warranted in the first trimester when the ovarian hyperstimulation syndrome occurs. Failure of the IVF, this is it's not important. This is thrombophilia at the IVF. The use, this is differentiation or the advantage of the use of the low molecular weight compared to the unfractionated heparin. Of course, there is a significant difference in the between the use of both, and these are a lot of studies, and the meta-analysis was done for these studies comparing the use of the unfractionated heparin and the low molecular weight heparin, with significant difference or significance that the use of the low molecular weight heparin is more beneficial. Guidelines for thromboprophylaxis in the IVF. I advise everyone in here to download this table from the Google and put it in the clinic before doing any operation for the patient. Please apply this table for your before cesarean section, before hysterectomy, before myomectomy, before any surgical interference, because the complications is fatal. The complication is fatal. And this is the area we must apply the thromboprophylaxis, not in the area of the overdiagnosis of the antiphospholipid syndrome or any patient who have just one abortion and we find that they write for her something increased the blood to the uterus. All of these are abuse, but the use is not applied. You have a cesarean section for an obese patient, got pregnant by IVF, having hypertension, having diabetes, and you do cesarean section, and you don't prescribe for her thromboprophylaxis, and at the 6th or the 7th day of your operation, she will die from thromboembolism. This is the area you must apply this, and I think it is a crime if you didn't apply this protocols for your actual need for your patients. This is here, any patient had previous thromboembolism, previous vascular thromboembolism, must receive. This is take score 4. Take score 4. This is patient had DVT, for example. not provoked by surgery. If it is provoked by surgery, it will take 3 scores. But if she had DVT without any surgery or without any predisposing factor, this is a dangerous patient and must receive the thromboprophylaxis during pregnancy. Previous venous thromboembolism provoked by major surgery, it will take 3. Known high risk of thrombophilia, again, it is very important. Medical comorbidities, for example, active bowel syndrome, heart failure, nephrotic syndrome, it will take 3 scores. Every with yellow color, take one, for example, family history of estrogen-related, known family history of thrombophilia, age of the patient during pregnancy is more than 35, obese patients, para 3 or more, smoker, gross varicose veins, each one, these are pre-existing factors. For example, if you have a patient and this patient is 37 years old and she is obese and she is smoker and you will do cesarean section for her, please give her. Please, this she needs. Don't perform cesarean section in the morning and discharge the patient in the evening. This is not medicine. Actually, in our clinics, in the urban areas, in our clinics, the patient, if I insisted for the patient to stay in the hospital for a single day, she asked me why. The doctor make the cesarean section in the morning, and just when the spinal end, the spinal efficacy end, discharge the patient. This is not medicine. This is of medical legal importance. And if I judge it for any doctor making something for the medical legal, I will give a punishment for this doctor. Please don't discharge the patient. I know this from, I was a member in the medical legal aspects, so I know a lot of that. 4 hours, 5 hours, full cesarean section, discharge the patient. Obstetric risk, if she has preeclampsia, if she have IVF, if she have multiple pregnancy, if she have cesarean section, selective cesarean section, not elective cesarean section. Elective cesarean section takes score 1, but selective cesarean section takes score 2. If you try to deliver your patients and change it to cesarean section, so this is, it will take 2 score. Prolonged labor more than 24 hours, postpartum hemorrhage, preterm birth less than 37 weeks, stillbirth in the current pregnancy, and the transient risk factors, surgical procedure in pregnancy. For example, appendectomy. If she had surgical procedure during pregnancy, she must receive antenatal prophylaxis by these men. If she has hyperemesis gravidarum, it is very important from the dehydration. It is the point you must apply in the first trimester the low molecular weight heparin. Current systemic infection, wound infection, if the wound is infected following cesarean section or following hysterectomy, especially in the diabetic patients, please give them prophylactic low molecular weight heparin. I think this is very important to apply, and you can apply this giving the score for your patients. High risk must take antenatally and postnatally. Intermediate risk, consider the antenatal prophylaxis. In high risk, must take. But in the moderate risk, score 2 or 3, she considered the antenatal and the postnatal prophylaxis. But in the first one, antenatal and postnatal. And if it is take in the yellow color, and each one from the yellow color take score 1. If you have 4 risk factors, so prophylaxis started from the first trimester. If she had 3 risk factors, the prophylaxis will continue from the 7th week of gestation or 28 weeks gestation. This is the same. Any surgical procedure, as I said, should receive, or the IVF. So the recommendation, the antenatal, women with IVF pregnancy, and the 3 other risk factors should be considered thromboprophylaxis with low molecular weight heparin. Recommendations postnatal. How many days we can give our patients? If the patient's in the red zone, you should give for 6 weeks postnatal. 6 weeks postnatal. But if the patient in the orange zone, that is to say 3 factors or 3 or more factors, risk factors, you can give only for 10 days postnatal the low molecular weight heparin. It does, this is very important, which agent should be used, low molecular heparin, and this is grade A recommendation. It doses, we will say about the doses, and there is no contraindications for the use except to those patients who are prone to have bleeding, and it is safe during lactation, and this is grade A recommendation. The dose according to the body weight. This is actually most of the patients between 50 and 90, so the usual dose is about 40 milligram per day or daily, and more than 90, 40 milligram, and more than 90 kilo up to 130, it will take 60 milligram per day, and up to 170, she may receive 8 milligram prophylactic dose per day. Contraindications, actually there is no contraindications except in those patients which will be exposed to bleeding and those patients who have some sensitivity reactions to the low molecular weight heparin. This is the main contraindications. If we have such a case, for example, 30 years old female attend the antenatal clinic, 10 weeks gestation, gravida 2 para 1, the current pregnancy was achieved through in vitro fertilization. She had ovarian hyperstimulation and she's a smoker. Do you want to give her the thromboprophylaxis? Of course. If we apply this to our, yes, we should give her. If we apply this to our model, so she's smoker, she will take 1. She has an ART, she will take 1. She's complicated by ovarian hyperstimulation, she will take 4. So the total score is 6. This patient must receive the thromboprophylaxis throughout pregnancy and 6 weeks postnatal. So this is very important to know. Should we take yes? Score is about 6. When should you start the thrombosis? From the first trimester, because she has ovarian hyperstimulation, should we start from the first trimester? This is the answer. What should be the dose of the low molecular weight heparin? I think its weight is about 70 kilogram or 80 kilogram, so we can apply the 40 milligram daily. What should be the dose? It will be 40 milligram per day. What about the postnatal period for such a patient? So this is such patients, she will receive the 6 weeks thromboprophylaxis. Thank you. Any questions? We have a time.
سانجس بروفيسور حاتم الجمل على هذه المحاضرة الجميلة. I ask about the duration of thrombophylaxis after success IVF. يعني with no risk.
We don't use unless during the IVF. It is not a routine to give the patient. There is no evidence that the success of the IVF depends on the duration. The duration, if we apply what we say. If it is ovarian hyperstimulation, you can start from the first trimester till the end of pregnancy and continue after pregnancy. If there is no ovarian hyperstimulation,
Thanks, دكتور.
هنبدأ الدكتور.
السلام عليكم.
الحقيقه احنا دلوقتي هنبدا احنا عندنا جراديويشن سيرموني. احنا بدانا السنه اللي فاتت اول ماستر ديجري في الاي في اف في جامعه عين شمس، وكانت دي يعني شهاده جامعيه معترف بها طبعا من المجلس الاعلى للجامعات، واكريدت من كتير من الاوروبيان سوسايتي ومن القشر يعني ومن الاس ار ام. كان عندنا اول مجموعه، ودي كانت الباكوره بتاعتنا، المجموعه اللي تقدمت. واحنا الحقيقه يعني هم مش كلهم، في ناس يعني ما عدوش من اول مره، فدول اللي نجحوا. يعني معناها ان احنا بندي شهاده حقيقيه، مش معنى ان انا بدي شهاده ماستر ديجري ان دي بيد شهاده يبقى هياخدها. لا، في عدد من اللي كانوا موجودين معاهم ما خدوش الشهاده from the first time. المجموعه الاولى يعني هنبدا الاستاذ الدكتور رئيس القسم الاستاذ الدكتور عمرو الحسيني هيكرمهم معانا على حصولهم على الفيرست اي في اف ماستر ديجري ان عين شمس يونيفرسيتي. بليز يلا. دكتور علاء عبد الله احمد. دكتورة مروة شوقي مصطفى. دكتورة منى عزمي زكريا. دكتورة شيرين محمد عبد المنعم. محل من المحل وانا عارف. اتفضل. دكتورة هدير سمير عبد الله. دكتور مازن جمال مرسي. دكتور محمد رشدي. في يعني في مجموعة تانية يعني هم من مناطق مختلفة من القاهرة، ظروفهم ما سمحتش ان هم يحضروا الجراديويشن. دكتور شريف فكري هنداوي، ده استاذ في طب عين شمس، ده استاذ عندنا ومسافر خارج القطر يا خارج مصر يعني، ورغم كده تقدم وحضر الامتحانات وحضر كل حاجه، وتقدم وحضر الامتحانات ونجح فيها بجد. هو اصلا بيشتغل اي في اف، ما هوش عشان استاذ معانا يعني. مصطفى محمد ابراهيم برضو من الطلبه الكويسين اللي نجحوا معانا، ما قدرش ظروفه انه يجي. وابتسام زين العابدين توفيق برضو هي مسافره خارج مصر فما قدرتش تحضر، بنقدم لهم التحيه وشكرا جزيلا لكم. هناخد صوره جماعيه مفيش مشكله، اتفضلوا. شكرا جزيلا. هنبدا الديبيت. هنبدا بقى الديبيت بتاعنا. بروفيسور اتفضل بيه. اتفضل. اتفضل. حد ساب تليفونه؟
So, this debate about screening for trisomy during pregnancy whether all pregnant women should be offered NIPT. Professor Dr. Umayma Idris and Sharif Abd Fattah. The debate will be professor from Emma Freeman and against Hatem Musa. Emma Freeman is a consultant in Obs and Gynae in fetal medicine, Sheffield in UK, and subspecialist in fetal and maternal medicine. Hello. And of course, we know, all of us, Hatem Musa, the consultant, specialist and associate professor in maternal and fetal medicine at University of Leicester. So I think this would be a great debate, and I'm giving the microphone to my dear friend, Dr. Sharif Abd Fattah.
اوكي نعم طيب اوكي Okay, ready? So at the back, please, if we can start the session, please. Okay, so yeah, no, I don't need it here. Okay, yeah, right. So this session will be a debate about should non-invasive prenatal testing offered to all pregnant women. So we'll have two great debaters, two great speakers. Emma Ferryman is a consultant in fetal medicine in Sheffield, and Professor Hatem Musa is consultant in fetal medicine in Leicester. So they will each present their point of view. We will not need long introduction about the NIPT. I think we all know what non-invasive prenatal testing is. We all know about free fetal DNA. So we don't need to waste time with long introductions. We need to go straight to the subject of the debate. But before we do the debate, I would like you to vote. You should all have the electronic voting equipment. So the question is, should non-invasive prenatal testing be offered to all pregnant women? If you think yes, please press A. If you think no, please press B, and then press OK, the green button at the top right. So yes, press A, no, press B, and then OK. We will have a display of the results on the screen, and please, you have 1 minute to vote. Okay, go ahead. Then we will do the presentations, we'll have a discussion, and then we will have another vote at the end, and we'll see who wins. Okay, please start voting now. Okay, you all got the equipment? You all got the voting electronic equipment? Some do not have the voting. Do we have enough there? Do we have more to give them? Right, so don't forget to press the green button, the OK button at the end. Otherwise, your vote will not register. Right, so far, the blue color indicates that the holder of that equipment has voted. The black ones, they did not vote yes, did not vote yet. So this is not yes and no, this is just whether you voted or not. So please check your number. If it's still black, maybe you did not press the buttons correctly. So please check it again. Three seconds, come on. Right, so we have 40% voting yes, it should be available. 26.8% voting yes, 37.6% voting no, and 35.6% did not vote. So far, the no vote is winning. So Hatem has an advantage. Emma will have a hard job to do now to convince everyone. So the debate will start now. So please, Emma, come in. And I don't think we need to go into this. That's a separate thing. Let's just focus on whether it's available or not. That's a completely different matter. Okay, so we have rules for the debate. No personal attacks, no punching, because we have to worry about Hatem Musa being injured if there is physical punching. Okay, Emma.
Good afternoon, everybody. Well, I'm on the back foot already, but my job as an obstetrician of over 30 years is to persuade you as to why I would offer NIPT as a first-tier screening test. And hopefully, at the end of my presentation, I'll persuade the no's to vote yes, and I'll persuade the abstainees to actually pick up and vote. So the background is that NIPT has been offered for fetal aneuploidies, and it's been in practice since 2011. So currently, we've got NIPT available in over 60 countries, and that means 10 million tests performed annually. There's been fast dissemination for this test. It's come through very quickly, and that's been driven by both pregnant women and by healthcare professionals. And the evidence for that from pregnant women is that they access the test privately if it's not available to them in their own country. And for some women, they'll even go abroad to access the test, which is called prenatal tourism. So currently, there's first trimester combined screening. This relies on a screening window between 11 and 14 weeks and is a combination of the nuchal translucency, beta-HCG, and PAP-A. So this is based on a risk assessment, and in the UK, currently our cut-off risk for a high or a low risk test is 1 in 150. Other cut-offs exist in other countries. So if you get a raised chance, if your risk is higher than 1 in 150, you'll be referred for counselling and you'll be given the offer of a diagnostic invasive test. And that might be either a CVS or an amniocentesis with a miscarriage rate approaching between 0.5 and 1%. For NIPT, we know that this is a cell-free DNA which screens maternal blood for aneuploidies, among other things. But actually, the topic of our debate this afternoon is just for the 3 commonest trisomies. You can get a risk which is either high chance, low chance, or no result. There can be false positives, false negatives, or inconclusive results. And the reasons for that could be placental mosaicism, there could be a low fetal fraction, fetal mosaicism, there could be underlying maternal chromosomal abnormalities, a vanishing twin, or a raised BMI with the hemodilutional effect. But whatever the reason, if you have an NIPT test that is positive, you need a confirmatory test with an invasive test. So this table shows you the performance for first trimester screening against the contingent screening and against first tier NIPT. And anyone can see that looks at this, that you can see immediately that the positive predictive value is absolutely excellent for NIPT, 96%. We do know that there's a lower positive predictive value for NIPT in women with trisomy 13, but the majority of these cases would be picked up by ultrasound in over 90%. So contingent screening. So this is when NIPT is offered to a high chance woman following combined first trimester screening, which has to be done, and I stress that, has to be done between 11 and 14 weeks. So if you're earlier, you're not amenable, and if you're later, you're not amenable, which means that people booking late in the pregnancy will be disadvantaged. So if you're in the first trimester, your detection rate will be 95%, with a false positive rate of 5%. If you're a late booker and you're going via the quadruple test, then the detection will fall to 85% with a false positive rate, again, of 5%. And remember, with this form of screening, there are no exceptions for women who have advanced maternal age or who have perhaps suffered previous pregnancies affected with aneuploidy. The NIPT result is currently between 5 and 7 days, but as we get better with the test, it will be offered between 3 and 5 days. Remember that you then have to wait for an invasive test for up to 3 working days in the UK, and if you have the invasive test, there is then a result which may not happen for 48 hours for all those people eligible for a rapid test, but remember, if the rapid test fails, then you could be up to 2 weeks. So for these women, there is the option of second trimester discontinuation of the pregnancy if they have a positive result. Whereas, if you have NIPT as a first tier test, you can have that test between 9 and 10 weeks. Your detection rate is going to be 99% for trisomy 21, with a false positive rate of only 0.1%. Compare that to your 5% false positive rate. You get a rapid result within probably 5 to 7 days currently, or 3 to 5 working days, and that would enable you to have an invasive test, a CVS, from 11 weeks, with a rapid result in most cases within 48 hours. So that gives women options. It gives them options to plan the pregnancy, but it also gives them options via the first trimester or second trimester continuation or discontinuation. This form of screening has been adopted in both Belgium and the Netherlands, and we'll show you some of the results. So this is the Belgium experience. This is the experience from Leuven. They adopt a universal first trimester screening with NIPT. So they are screening babies not only for aneuploidies, but also for other genetic disorders, including single gene defects. This has been introduced between 2014 and 2018, and this has halved the number of prenatal tests, both CVS and amniocentesis. And there have been 1/3 less babies born with trisomy 21. Because this test has been in situ for a number of years, the cost has also reduced, because that is what my adversary will say is one of the disadvantages of NIPT. So in Belgium, the cost of NIPT is now €150, and that would be in line with the cost of a first trimester screening test in the UK. So what are the advantages of first tier NIPT? Well, firstly, there's no window for testing, so we're not disadvantaging late bookers. There's a higher detection rate, and there are fewer false positive rates. So most women having this test will get a final result after a single test. And what's most important is that most pregnant women, and my colleague sitting next to me, her daughter is currently pregnant. She just whispered in my ear that if she had a choice, she would have NIPT as a first-line treatment. That is what most women would choose. There are also additional benefits, which include the detection of other maternal conditions, for example, cancer. And remember that our pregnancy demographic is changing worldwide. So our women are getting older and they're having more comorbidities, and therefore you get some degree of reassurance for a high-risk pregnancy in that early first trimester. There's also an opportunity to introduce a better first trimester screening test for preeclampsia and fetal growth restriction, because we would get rid of PAP-A in the first trimester and we would substitute it for PLGF. So these are the perceived disadvantages. Perceived, I say. So cost. So in Egypt, currently an NIPT test is between 7,500 and 8,500 Egyptian pounds. In the UK, the test is around 350 British pounds, which equates to just over 13,000 Egyptian pounds. In Belgium, where this test has been available for a number of years, that cost has gone right down to 150 euros, which equates to 4,900 Egyptian pounds. So with the introduction of first-tier screening, the cost is going to come down. Also, there's been an improvement in the turnaround time. So I'm reliably informed that in Cairo here, if you have the test, you may have to wait up to 2 weeks for a result. In the UK and in Belgium, it's 3 to 5 working days. So there's a fast turnaround for these women. Yes, you can argue that if you do earlier screening in pregnancy, that you may detect some fetuses with aneuploidy that may have miscarried before the 11 to 14 week screening window. But remember, that will also give us some demographical data on aneuploidy. For women who are having an NIP test before the 12-week scan, there may be an incidence where the fetal abnormality may be detected at 12 weeks, which would warrant invasive testing. And what we've got to make sure that a low-risk NIPT test does not falsely reassure these women, and that will rely on absolutely excellent pre-test counselling. The other perceived disadvantage is the abolition of PAPE to test for placental growth restriction. But as previously stated, PAPE is a second-rate test, and we could then advocate PLGF as a first trimester screening test, which performs much better. So the suggested screening strategies would either be for first-tier NIPT, you could either do it at 9 to 10 weeks, so a standalone test with an additional 12-week scan, or you could do it alongside the 12-week scan. That means that the first trimester dating scan could actually be put into making it an anomaly scan, so we could look for more abnormalities in the first trimester. So there's an opportunity to develop that, and that data has been favourably received by the NCARD's UK data. Don't forget that we're going to carry on. We're still going to do the nuchal translucency measurement because that is an abnormality marker. As I've said, we're going to substitute PLGF for PAPE, and then we'll get an improved risk for those women at risk of placental growth restriction, and that will enable us to do further surveillance. The most important thing with all of these tests is that there's accurate pre-test counselling. Because otherwise, if we don't counsel these women accurately, then some women may not attend for the 12-week scan, having had NIPT at the 9 to 10-week scan. There's also a small risk that women may be falsely reassured by a 9 to 10-week low-risk NIPT result, and then they may subsequently find an abnormality at 12 weeks on that screening scan. So it's imperative that they're appropriately counselled. So in conclusion, I would advocate to you that first-tier NIPT is what women want. It has a higher detection rate, it's got a lower false positive rate, and most women will have a result after a single test. It allows earlier detection of aneuploidy, allowing pregnancy planning, or the choice, and choice is imperative for women, for pregnancy interruption. There will also be earlier results for women who have had the experience of a previous aneuploidy, and it will reduce their anxiety. In our women, where there's a changing demographic, they're older and they've got more comorbidities, there would at least be some reassurance at an earlier gestation that from one point of view, their pregnancy is progressing well. And as far as cost is concerned, well, I'm afraid that's not an argument because costs will fall, as has been shown to be the case in Belgium. So, I'm asking you, as a room full of experienced obstetricians, If, as obstetricians, we put women's health and their choices first, why would we give a second-rate screening test and ignore maternal choice? Thank you for your attention.
Thank you, Emma, for putting your point very elegantly. So now I will invite Professor Hatem Musa to put his point. And I think, just to remind everyone, that we're not talking what to do with the result. Whether the women decide to end the pregnancy or not, that's a different discussion, that's a different choice. I think what we're discussing today is whether the test should be available or not. Okay, Hatem, please.
Good afternoon, everyone. First of all, I would like to thank the organizing committee and the Professor Amro for the invitation. And it's so nice to come back to Egypt to meet friends, families, and eminent clinicians. So thank you. Emma, you made it very difficult for me. So what is Emma, before I start, what is Emma proposing? Is let us scan the woman at 9 weeks. Is that a cost? No, it's not cost. Let us scan her again at 11 weeks. Is that a cost? No cost. Let us offer her PLGF and the BAP-A. Is that a cost? No cost. And what is all about? Because the woman would like that. And if you believe the woman would like that, let us have a look here on the reality here. So Emma has already done a proposal that 85% we will detect of Down syndrome. And there is a 5% false positive rate. I am a guy who works with numbers. Don't tell me 85%, don't tell me 5% will need amni or CVS. I need numbers. So what is the numbers? This is a UK figure, and this is Ain Shams University for simplicity. If I say to you, Ain Shams University deliver 10,000 women a year, so 22 of them will have Down syndrome, 6 will have trisomy 18, and 3 will have trisomy 13. If I offer them the screening as we offer, what will happen? You will pick up here, you will miss 4 cases of Down, 1 case of trisomy 18, 1 case of 13. So in reality, offering a screening for 10,000 women as we offer, you will miss 6 cases in Ain Shams University per year. Now the question I am asking you, and I am asking Emma, how many cases of Edward and Batau has been missed in your hospital in the last 5 years? Do you really miss that on ultrasound, or do you really miss that on ultrasound? The answer is no. We don't miss trisomy 13 or 18. So in reality, the whole screening program will be costing you here to screen 10,000 to look for Down syndrome to avoid missing that number of cases I showed you earlier on. Let us talk about money here. The amount of cost I got was a bit different. I was told 12,000 or 15,000 or 8,000, so the round figure is 10,000. So Ain Shams University have a 10,000 delivery, and the test cost 10,000 pounds, and I will ask Professor Amr to give me 100 million to screen women at Ain Shams University per year. And what I would like to achieve is to avoid to get the missing cases of Down syndrome. If you have that money, please use it. But you have to ask yourself the question, would I spend 100 million pounds to avoid missing these cases every year? Now, Emma talked about very nicely about let us do it at 8 weeks, let us do it at 10 weeks, let us do it at 13 weeks. But let us talk about what is the factor affected. Do you really believe as a woman in Egypt could get pregnant at the age of 16, 17, 18, will have the same risk as a woman at the age of 40? The answer is no. You need to direct your intervention according to your risk. So look on the age. Secondly, we believe that size does matter. What Emma didn't tell you is that in women, on average weight of 100 kilograms, 7% you'll not get a result because there isn't enough fetal DNA. Even if you do it at 9 weeks, there isn't enough fetal DNA in 20% of cases. So you're going to repeat it again. So what you're doing is wasting your time, and the woman will be stressed out. And this is the work from Kipros saying to you ethnicity as well has an effect on your free fetal DNA. And if you see here at 25 millimeter, you will miss here 20% of cases. So please don't try to do it at 8, 7, 6, 4 because you're going to miss quite a lot. She talked about vanishing twins, but I'm asking, what is the evidence for triplets? Quadruplets, we can't use it. What is the evidence when you have an empty sac at 9 weeks? When you have a fetal ball, no fetal heart? What are you going to tell her? There is no answer from her yet. Placental mosaicism is 1%. We have cases that the placental mosaicism affects the placenta or affects the fetus with Down syndrome. So what will happen? You will have a fetal DNA in the circulation coming from the placenta, but the baby is normal. And the vice versa. You will have a fetus with mosaicism, but the placenta is normal, giving you a false result. How many cases? You will have 1% of placental mosaicism. So let us just get it clear in our mind. We have a 1% placental mosaicism. 4% we don't get a result. We have a false positive. 5% of women are twins or triplets, but we say we could offer it to all women during pregnancy. In reality, we can't. And we have to be selective on what we do. It's very important to take in consideration companies as well, because the detection rate for companies is different. And I know Emma presented very elegantly the talk about Down syndrome, but she never mentioned trisomy 13 and 18 and Turner syndrome. The detection rate in this condition is already low. So why we don't take that in consideration? Why we just focusing on Down syndrome 99%? Why we're not talking about the 90% to 93% in trisomy 13? Why we ignore that? And Emma talked about amniocentesis and the risk of miscarriage. But I will invite all of you to read the paper by Solomon. So Solomon said, from France, in the current France, he said, if you wanted to compare the risk of miscarriage, you have to compare like for like, apple for apple. What does that mean? You have to compare the risk you carry amniocentesis in women with high risk with women with high risk has no amniocentesis. What you found there is no difference in miscarriage rate. So the miscarriage rate we are talking about that if you do a needle test, you increase. It does not exist. In reality, if you do a CVS, it's lower. So what is the implication? Something very important. We're talking about women's choice. We try to stigmatize things here. I just would like to invite you to look on those group of people online. We just try to say we wanted to create an environment where there is no Down syndrome. But how about other things? So if you look on Sujit, who is a Down syndrome playing 7 instruments. If you look on Isabella, she is the first fashion designer. If you look here on Chelsea, she's the winner of Olympics. So the issues here is not about Down syndrome. In reality, the issues here, if I could assess the brain function and to know how I could help these people, that would make a difference. Let us get it clear. If I ask you, choice, what do you want? Every one of us want a very nice car, a nice house, a nice garden. So if we say to you, what does the woman want? The woman wants everything. She wanted money from her husband or family. She wanted to have a scan every week. And she wanted to deliver in a private hospital and have a celebration with a healthy baby. But can we offer that? Can we give them? Can we convince Professor Amr to give 100 million a year for Ain Shams University for a screening? So before I leave, I would like to look at that. This is the UK screening policy. And I will say to Emma, in UK, we have lung cancer, we have breast cancer, we have blood pressure. Women got breast cancer at any age. But do we really screen all women? The answer is no. We screen women with breast cancer in UK between the age of 50 to 70. Lung cancer is the same. Blood pressure for adults is the same. So the question for Emma here, if you really believe we should offer a screening for all pregnant women to pick up extra 6 cases or something of Down syndrome, should we screen all women for breast cancer? Because women could, the last cases I had was breast cancer died. Most of them I seen during the pregnancy. You haven't had a talk today about cancer in pregnancy. Should we offer all women screening for breast cancer at all age? The answer, we can. We offer it only between 50 to 70 here, using the mammography every 3 years in UK. Before you vote, I would like you to ask yourself the question, do you really believe that all women should be offered the same or age should have an effect? Combined screening has been criticized for the false positive result. But the question I'm asking you and I'm asking Emma, we got 4 to 10% no result. What do we do with them? We do amniocentesis. But we call them no result, not false negative, not false positive. Where we should direct our money, I put a list for you here with maternal age and the complication. This is the gestational diabetes. This is placenta previa, placenta accreta, growth. Where you want to invest your money, you have to decide what is your priority in the country, how you direct your money. Should I invest the money to pick up growth problem, to pick up placenta accreta? We have 2 placenta accreta every day coming to Ain Shams University, I've been told. Should I invest the money to develop something to help these women? Or should I look for the 6 cases that I wanted to detect during the year? What would be my priority? Thank you.
Thank you very much, Dr. Hatem. Thank you, Emma, for your presentation. But I'm with Hatem and with Emma. How? I'm working at Qasr Al Aini, and of course we had 13,000 deliveries per year. So I wouldn't suggest to offer our pregnant patient the NIPT in Qasr Al Aini or Ain Shams, because I agree with you about your concept. We cannot do it. We have a lot of money, we can save it somewhere else. But I'm talking about my private patients. أكيد كلكم لحظة delivery of the baby, this is a very important point for you. يعني for me, every delivery I have to look to the face of the baby, whether it's a normal baby or it's longer. Trisomy 21. I'm sure that everyone in this hall, he is caring about the patient, and when the patient is having a trisomy 21, it will be a hell for you. The patient will ask you, you did for me ultrasound several times. You did for me everything. I came to you 9 months, and by the end you say to me that your baby is abnormal baby. She's not accepting. That's why in my private work, I'm agreeing about what Emma is saying. Because you know, I offered my patient the NIPT at 11 weeks. So the fetal fraction would be good. And I combined this with the first trimester screening. So when you do this and the baby approved to be normal, inshallah, you be sure that the baby will be good. So in the general practice, I agree with you. In the public or private practice, I agree about Emma. The patient who deliver a baby with trisomy, of course, you know, here in Egypt, we don't have the facilities like in England that your baby will be a musician or will be he can complete even his education. I have one of my patients, she is having a baby who is trisomy 21. She is suffering to find a school for this baby. So unfortunately, in our country, the trisomy 21 does not have rights and does not have the chance to be a good like in England. So we have to be careful very much about our private work. And let me ask some of the audience here. I can see Dr. Hassan Salam. Dr. Hassan, would you offer your patients the NIPT routine for all patients, whether it's a low risk or high risk or not?
Thank you very much for the question. I find it a bit difficult to differentiate between the private patients and the public patients. It's really a matter of economy again. It's a matter of economy. We would love to do all tests to all our patients. But maybe what Emma doesn't know is that our test is not done in Egypt. It is sent abroad, usually to Germany or to America, and then we get the result. This is how it is expensive. So I offer it to everybody. And I do the counseling, and it's up to the patient. She will think about it, but if I am, again, it's different. Are we talking about a community where medicine is nationalized, like the UK? Or are we talking about a place where medicine is private, like Egypt and the United States of America? The patient is going to pay everything. So I don't think there is an easy answer for this. So both of you are right.
And of course, I would like to say that with the social media, patients are reading a lot about this test. So she will come to you, why you didn't do for me this test? NIPT, I have heard about it. You didn't offer it for me. You know what I'm doing in my clinic? I offer to the patient. And if she's refusing I wrote in the chart that the patient has been offered the NIPT and she refused to do it. So this is very important for the medical legal program. And can find Dr. Sharif. I would like to know your opinion.
I would like to go one step before I offer the patient. I'm going to ask the patient, are you going to accept termination of pregnancy or not? Because many of our patients are so religiously related that they are not going to consider termination even if you have a Mongol baby. So my first question to the patient is, are you accepting termination or not? If she's going to accept termination, then I would offer her the test. But she said that, no, I'm not going to accept termination under any circumstances. Then there is no point of offering the test for her. It depends on the patient.
Dr. Sharif, if the patient is not accepting termination, are you going to do for her the first trimester scan or not?
What do you mean by first trimester scan?
The ultrasound scanning.
Yes, I'm going to her, and she's, according to the counseling, I would understand that she accepts the outcome of pregnancy irrespective of the outcome, so long as it's compatible with life. The only exception for the possibility of termination, if you diagnose, for example, an encephaly, then I think most, if not all, the patient will accept termination. But if the baby is compatible with life, many of my patients, at least, will not accept termination.
Okay.
Thank you very much for the debate. It was very, very good. I think my question is, using the screening tool that has more results that are positive, we're going to end up doing more amniocentesis. So just using your model of 10,000 hospitals, how many healthy babies would you kill from miscarriage using an amniocentesis that was unnecessary versus the other version where we wouldn't do the amniocentesis because we're more reassured by the NIPT?
Dr. Hatem can answer this. Dr. Hatem can answer this question.
There is no difference in the risk. The risk you do amniocentesis if what you believe that the amniocentesis increase your risk, but in reality, this is a false belief. I'm a fetal medicine consultant. How many cases I had in the last year with miscarriage? 3 years with miscarriage. You are the same. I will ask him is the same. You miscarry the baby who are unhealthy. See, if I have a baby who hydropic, I do amniocentesis, the woman could miscarry. But I'm asking you how many healthy baby had amniocentesis in your hand, had a miscarriage in the last 5 years? That is the question you need to ask yourself. Solomon paper is very clear. You don't increase the risk of amniocentesis. Amniocentesis does not increase the risk in high-risk women. The answer is clear.
So I would like to strongly disagree with that. So what I would ask you is, in your regular practice as a fetal medicine consultant, if the woman comes in with a high-risk test, do you tell her, I've not had anyone miscarry from amniocentesis in the last 3 years? Or do you give her the material risks, and I stress the material risks, in compliance with Montgomery counselling? Do you give her the risks, as the RCOG would give you, of 0.5 to 1%? And your answer to your question, in my practice, my miscarriage rate is between 0.5 and 1%.
Okay. So to answer your question, Emma, I quote the department miscarriage rate. I don't quote my own. Unless the patient asks me how many miscarriages you had. So I say to her, like what you say, the miscarriage rate is 0.5%, but that include not only the cases for high risk, but include cases with fetal anomalies or malformation.
رأي حضرتك دكتور عمرو.
Well, I think the NIPT test really is a great test. We can reassure the patient that the baby is normal, and even some of them, they can prepare themselves if the baby is not normal to carry their own life, after that, which is very important for that. I tell the patient that this is a very good test. We can know very early. It has a 99% accuracy rate. And there are other tests, they are not that accurate, can be up to 90% for the double marker and the first trimester screening. And if you go for the triple test, it can be 65%, and you will do a lot of amniocentesis for that. And then I'll tell them that this is a quite expensive test, which will cost you around between 8,000 to 13,000, depending on the lab in Egypt. And some of the patients, also I asked them, like Dr. Sharif said, that if you are not going to do anything, then maybe you should not consider the test.
Okay, thank you, everyone. Our time is up, so let's have a final vote now. So please use your electronic voting equipment. If you think it should be screening for TRASB during pregnancy, all pregnant women should be offered NIPT. If you think yes, please press A. If you think no, please press B. And don't forget to press the OK button at the end, the top right one. We have 1 minute to vote. Go ahead. Some people are already voting very quickly now. Who convinced you?
Take care, the question is offering, is not you have to do it. It's offering, you have to explain to the patient that we have an NIPT testing. So it's an offering.
Okay, 15 seconds to go. If you're still black, please look at your equipment, look at your number, and vote. Right, the moment of truth now, Emma and Hatem. Right, so actually, the percentage of voting yes has increased. It's now 35%. I can't remember the figure, I think it was like 28% before the debate. But also the figure for the no vote has increased from like 36 to 39. So actually, I think we can say we're equal because the yes vote has gone up, the no vote has also gone up, but not with the same percentage. So well done, Emma, well done, Hatem. Thank you very much.